Thank you all. Welcome to this meeting of the Perth and Kinross Integration Joint Board of Wednesday, the 11th of December 2024. My name's Colin Stewart. I'm a principal I'm chair of the board. I'm joined by Jackie Pepper, the Chief Officer, and Donna Mitchell, the Chief Finance Officer, and by Scott Henry, who is the clerk to the board. And we also have attending Jess Guild, who's going to be the assistant clerk to the board to replace Adam Taylor. So we thank Adam for his long years of service. I mean, to the IJB. Okay. Do we have any apologies or substitutions?
Apologies from Heather Dunk, Aaron Singh, Brian Jones, and Melanie Devlin, who will be appointed officially today, but she's not with us.
And we have some members of the board joining online as well. So, are there any, item 2 on the agenda is declarations of interest. Are there any declarations of interest on the agenda today? Seeing any? Item 3 then is the minutes of the meeting or the last meeting, which was on Wednesday, the 2nd of October 2020. We agree in the minute. Great. Can we agree the minute of the last meeting? Great. Okay, thank you. And item 4 on the agenda is the action point update. Was that satisfactory for everybody, or are there any questions on the action point update? Sandra, did you want to come in?
Yeah, I'm sorry, I lost my connection there, so I'm not clear.
Sandra, it looks like your connection's been lost again. I'm not sure why I'm saying that if you can't.
Oh,
Sandra, you're back.
Sorry, yeah, I'm sorry, my signal doesn't appear to be very good. I lost connection, so I'm not clear. Have you covered the minutes of the last meeting?
Yes. If you've got any questions on the minutes.
I have. I note that I raised a question at last meeting regarding in particular GP vacancies. And the answer at the time was relatively non-specific around that it might be something that would be could be covered at a development meeting in the future. But I'm noting that vacancies and recruitment and retention is relevant to a couple of the papers today. So it would be helpful if my question was from last time was noted in the minutes, please.
Okay, I think we could probably make that adjustment and maybe send around a note in response to the question. That's okay, we'll take that as an action.
Okay, that would be lovely.
Okay, are there any matters arising from either the minutes or the action point update? I guess we've just dealt with one of the matters arising, but anything else? No. Okay, we will move on then to the membership update. Jess, do you want to cover that?
Yeah. So we have the appointment of the public health representative Heidi Douglas is to replace Dr. Emma Fletcher. The public sector representative Lindsay Hunter has been reappointed. We've got a new third sector representative, Melanie Devlin, who gives her apologies today, and the IJB service user election results. Sandra Auld has been reappointed, and we have Nettie Sutherland with us, who replaces Sir Ian McCartney.
Thank you. So yes, I was going to say, following the public partners user elections in November, the service, yes, the service user public partner membership, the two top candidates in the election were Sandra Auld and Nettie Sutherland, who joins us today. Can I formally ask if the board agrees to appoint Melanie Devlin as the third sector public partner representative and Sandra Auld and Nettie Sutherland as the service user public partner representatives? Agreed? Everybody nodding? Agreed. Those online. Thank you. I would like to, in particular, though, take a moment to thank Sir Ian McCartney for his considerable voluntary contribution to the Intervention Joint Board. Sir Ian was also co-chair of the Strategic Planning Group and brought considerable experience to the work of the board and promoted the voice of service users with real passion. He was diligent in his attendance and his extensive contribution to our discussions and the thinking of the board on all matters relating to health and social care in Perth and Kinross. Ian is unable to be with us today, and I shall write to him on behalf of the board to thank him for his substantial contribution. I'd also like to thank the community engagement team in the Health and Social Care Partnership for facilitating the election process, bringing rigour and transparency to the process and enabling access to many people who interact with health and social care services in Perth and Kinross. Thank you. Okay. Item 7 on the agenda then, we move on to discuss the delivering on the strategic objectives. We would normally go first of all to the Chief Officer for the strategic update, but we have two guests with us today who are only going to be addressing one paper, so I've invited them to move up to the top of this part of the agenda. We have Bill Atkinson, who is Chair of the Adult Protection Committee, and with him Ian Wilkie, who is the Adult Protection Coordinator. So the first of our strategic objective items is the biennial report for 2022 to 2024 of the Adult Protection Committee, and I'll invite Bill Atkinson to introduce the report.
Thank you very much indeed, and thank you for inviting us along this afternoon to give a focus for adult support and protection work. I appreciate the size of your agenda, so try and be brief, and I'm mindful that this is a biannual report that's produced every 2 years as a statutory requirement by the Adult Protection Committee. But for many years now, we've produced an annual report along with the Child Protection Annual Report and the Chief Social Work Officer report to provide a suite of assurance and information and governance around the work of the Chief Social Work Officer and the respective protection committees in Perth and Kinross. You'll see from the report that the trend over the last few years has continued to be one of rising concern reports for vulnerable adults and the increase in the number of referrals for consideration. Whilst the majority of these concerns involve those over 65, and in particular over 80, there's been a continued rise in those facing mental health issues. However, despite the rise in the number of concerns, all of these have been dealt with in the appropriate timescale in over 80% of cases. And that's a considerable achievement, and I commend the council officers and social work services for that performance. In the last year, the rate of increase has slowed down as the committee further develops its data collection. We are being more able to interpret it quickly and changes in patterns and the reasons for that. And the report covers some of these, including a greater focus on early intervention, as well as a statutory response, and that's getting in earlier and supporting vulnerable adults and their families, and hopefully therefore avoiding a statutory intervention at a later stage. One of the main features of the committee has been the work that we've been trying to do in terms of self-evaluation and improvement. And we've done, as you'll see in the report, a number of activities, audit, data analysis and learning from case reviews. However, in this particular report, the timescale covered by this report of particular significance is the external scrutiny by the Care Inspectorate and Health Improvement Scotland, which was published now almost 2 years ago, over 2 years ago. But this provides external assurance that not only the arrangements in Perth and Kinross are of a high quality, but there continues to be a strong commitment to develop the adult protection improvement plan. Supporting adults of vulnerable adults in Perth and Kinross is not the sole responsibility of the Adult Protection Committee. And in the period of question by the report, there's been a strong focus on strengthening public protection arrangements across Perth and Kinross under the leadership of the Chief Executive and the Chief Officer Group. There's clearly significant advantages in improving cooperation and collaboration across issues of common concern, including the transitions, cooperation and collaboration across training and development, violence against women and girls, and substance misuse. Whilst the improvement work of the Adult Protection Committee has been effective in driving up standards over the years, the committee recognises in this complex area of work ultimately it's the quality of the practitioners that ensure protection for vulnerable adults and their families. And therefore, training and development, support and engagement of particular practitioners, particularly by the lead officer, has been a major priority and will continue to be so in the future. Whilst the report is about a reflective account of what we've been doing over the last 2 years, it also highlights some of the areas for improvement. And as I just said, strengthening our public partnership arrangements to safeguarding is one such priority for us. Working together with partners to safeguard older adults, who, as I said earlier, are the main area in terms of referral numbers. But as I was also mentioning, young people or younger people, particularly in transitions with mental health issues and complex needs, are another area we need to focus on. And engaging adults fully in the process, not just in terms of the process for those in some form of adult protection measures, but also in the service development that we're trying to consider over the next 2 years and giving them a real voice in that. That's all I would want to say by introduction. As I said, the chair has already mentioned, Ian's with me this afternoon. I'm grateful for him for his support and for compiling most of this report and the details behind it. Take any questions or comments. Thank you.
Thanks very much, Mr. Atkinson. Do we have any questions or comments on the adult report? Mr. Black.
Thank you very much. Page 33 of 272, and you've got the ASP and investigations and percentages. What happens when there's more than one issue happening in that? How is it recorded? Is it recorded under physical harm, emotional harm, or is it recorded separately?
Yeah, so you'll see throughout the paperwork that we've seen how we collect our data as our kind of key priority for us. And we know that if we can collect the right data, we can make sufficient changes, kind of going on in terms of how we approach early intervention. The more we know about what's going on currently, we can focus on these key areas. The data set that we're currently reporting on is based around a kind of an older recording system called AIS. We are moving to Mosaic very early next year, and the work that we've done with the Mosaic team has allowed us to build a greater data set that gives us much more data than we currently have to understand exactly what's going on. It's unlikely that we would experience someone with only one category of harm. We tend to see kind of multiple categories of harm, and some of our more complex bits of work would support those where there's more than one. You're absolutely right, more than one category of harm. So the data that we currently have does not able to give us that detail, but certainly when we move to Mosaic, it might not be in the report that might come here next year, but the year after, we'll be able to do that.
Thank you very much.
Have any more questions on the report? Comments on the report? Give a sec for anybody online with any questions. Oh, sorry.
Right, just a comment. I've done a piece of work with Ian and it's in the report. Bill mentions having voices heard, and the short version is the piece of work we're doing is if a provider has been involved in an LSI, I go back out and my counterpart in Dundee does this as well, and it's what we've done with Ian. We go out and we speak to the provider, the manager, to get their opinion on how the process worked, and we've based this on IRIS guidance. And there's been a lot of interest out with P&K Dundee in this piece of work that we're doing. As recent as yesterday, one of my colleagues in one of the bigger partnerships in Scotland was asking again about more information about what we're doing, because we're getting that richer, more rounder review of LSIs, not just from the partnerships perspective or the service user, but actually from the providers that are involved in it. And we've actually adapted the processes around it. So just to make a comment that, as Bill says, it's important to get all the voices involved in LSIs and ASP.
What was the IRIS guidance that you mentioned?
We can forward it on. It's the Institute for Research and Innovation in Social Services, and they're reviewing the LSIs, and Ian and I are on the national group based on this piece of work that we're doing, and they're trying to build into the new processes what we've done here in Dundee.
Okay. Another question.
Another question on that. Yeah. Again, that's maybe going on for that. Once we're able to get that and in future, it's bound to change our priorities and finance towards supporting priorities. At this moment in time, what is the impact when we're recording in that manner?
Well,
against strategy.
Yeah. So I think what you can see over the last two years is we've given greater investment to how we support and how we approach mental health, because we see that data quite clearly coming through. There's an increase. We can see some of the data already pointing towards, although the older adult will continue to dominate our adult support protection work, there's been a real growth in a number of referrals that we receive for the younger adult. So as Bill quite rightly says, we're starting to join up with those who also support the younger adult, because as much as Adult Support Protection Act is predominantly a social work function, it's very much a joint, integrated, multi-agency approach to this. So we're starting to blur the boundaries of what was predominantly adult support protection and what might be child protection into actually what can we both do together. Mm-hmm. So we've already got a richness of data that's allowing us to, again, fulfill that commitment to early intervention. We know the sooner that we can get in with the right people at the right time, that we can prevent us from getting to that acute bit where we need to apply the law. Because as much as it's there to be used, we would rather we didn't use it. We would rather we got the right supports to the right people at the right time and not have to use the Act. But as again, it's been able to use that data and think, where are the pressures and where do we need to go? Now, I could sit here all day and explain how that might be in the next couple of years. But maybe when I come back the year after, I'll be able to share what we've done. Communities is another example of where we're going to be taking this, because probably for us it's a really untapped resource that we're really keen to explore. But quantitative data, that numbers is fine. So I can tell you how many adult support protection stuff we've done. So the answer for me is so what? If the adult's not feeling safer because of what we've done, then what's the point? So as Dave quite rightly says, we've really pushed ourselves into this feedback. Tell us how it's worked for you for large scale investigations, which has been proven a bit of a national hit, really. And so what we've been doing with Rachel, and you're going to hear a paper around participation, and so in this next year, we're putting this boat out around going back after we've done an ASP with someone, getting feedback from the adult and their unpaid carer to tell us, well, what have the changes been for you? So not only we can give you the numbers, we can actually give you some of the real life experience of what it's meant for these people.
Thank you.
Okay. Oh, Chief Officer.
I don't know if this is a question, but it's just, I think one of the things that is notable in this report is the improvement or the increase in the availability of independent advocacy within adult protection processes, which was something that, you know, as a recommendation from the inspections. So just, I think given that we're talking about participation, it would be helpful, I think, maybe just to see what that has meant and what that looks like.
Yeah.
No, you go.
Well, you got yeah. So yeah, you're absolutely right. That was one of the kind of recommendations that did come from inspection. As Bill quite rightly said, we received a really good inspection, but they highlight a number of a couple of areas that we could improve on. And one was the kind of role of advocacy. But when we talk about participation, advocacy is crucial. And we need to make sure that we have done everything that we possibly can to make sure that the adult has received multiple opportunities to be supported by an advocate throughout the whole adult sport protection journey. We need to be absolutely assured that if there's an unpaid carer, that they have been given every opportunity to receive advocacy support. But it goes beyond that, and what we've done is we've just produced a position paper around effective participation in adult sport protection case conferences. So there's an aid memoir for the chairs to check in that we have done absolutely everything that we can for the adult to participate as much as they can. And when I talk about rolling out Mosaic, we've refreshed the assessment forms where in the past there was an opportunity for the council officer who was doing the assessment to rule advocacy in. We've kind of turned it on its head and actually said, but actually I now need you to rule it out. You tell me why there's no advocacy involved with the adult at this point in time. So it gives us a better defendable position and actually gives us that assurance that you know, where advocacy might not be wanted by the adult, and they may be legitimate reasons why they might not want someone to be there on their behalf or with them or actually to attend, that we've actually asked these questions where right now we don't.
Just really a question, but the observation when you've got the age group is most at risk. 16 to 24-year-olds are 10%. That's the lowest percentage.
Yeah.
I'd have thought that the younger ones would have been, you know, especially 16 to 20, maybe, but 16 to 24. But I think that's quite a low percentage, really.
It is, Maureen. I think you're absolutely right.
I think one of the issues is that as we were talking about earlier on, the statutory involvement of adult protection is limited by the statute, by the legal framework, which is a quite narrow definition. What we've been trying to do is widen that definition, not just to what we can intervene on a statutory basis, but how can we support vulnerable young people. So what we're starting to see through that approach is that more young people are coming to the attention of adult protection, not necessarily because they need a formal legal intervention, but because they're vulnerable and need the support, and looking and offering that support through an adult protection lens, as well as a child care lens, as well as a criminal justice lens, as well as a mental, altogether offers a more rounded potential picture, because some of these young people's needs are quite significant, and no single perspective would be enough to actually deal with all the issues. So we're hoping that the numbers will rise, and we're hoping that it won't be about us intervening in a legal framework, but actually as intervening in terms of trying to coordinate better support for the needs of these young people. And I think we've already started to see signs of that, but that's why it's really important, as I was saying in the introduction, that we see ourselves as contributing to a public protection approach rather than a siloed report, which is about children's services taking the case so far, and then handing it on to somebody else, and then eventually handing it on to adults when already some of the issues have become well established. And as I say, we're starting to see the value of that, and we're keen to be involved in that approach, but it needs all the partnerships to work and contribute their bit to that.
Okay. No more questions or comments? Can we as a board note the wide range of work being carried out by Perth and Kinross Adult Protection Committee and partner agencies throughout this reporting period to safeguard adults considered to be at risk of harm, and endorse the contents of this Adult Protection Committee annual report for 2022 to 2024. So, agreed. Thank you very much. And I would just like to say, I think on behalf of the board, thank you very much, Ian and Bill, for the report and for coming along and answering the questions. But more importantly, thanks very much for the hard work that goes into making sure that we've got robust processes and we're taking robust action in respect of adult protection in Perth and Kinross. And thanks to all of the staff that are supporting that.
Thank you very much. Thank you.
We'll let Mr. Atkinson and Mr. Wilkie leave, and then we'll move on with the agenda. Thanks very much. Chief, you are giving us a verbal update.
Thank you very much. There's just one area that I would like to provide an update to IGB members in relation to the national mission to address delayed discharges, to provide you with an update. Since we last met in October, the Collaborative Response and Assurance Group, known as the CRAG, which is jointly chaired by the Cabinet Secretary for Health and Social Care, Mr Neil Gray, and Councillor Paul Kelly, the COSLA spokesperson for Health and Social Care. That continues to meet weekly with chief officers and other participants attending. And at the meeting that was held yesterday evening, it was noted that the national position in the last week, after a rise in overall numbers witnessed since early October, has begun to come down, which is pleasing to see. Our local position at the meeting yesterday evening was that we remain in the moderate category, which describes a requirement to ensure that we make moderate reductions. And that data is based on information to the 4th of December. However, our local data for the current week shows that there's been a significant improvement with the total number of people who are experiencing a delay in their discharge home from hospital. And we're now notably below this target set, which is 34.6 per 100,000 people. Today that we're sitting at a rate of 24 per 100,000, so it's well below that. And our total number of delays in acute wards in PRI, and Monica, you may have bang up to date information, but this morning it was sitting in 7 in PRI and 2 in Rhine-Wales. So the impact of that improvement across the whole system is significant. And notably, there's been no diverts from Perth Royal Infirmary to Ninewells for the last 4 weeks or so, which I'm told is unheard of. So I think that, and for many years it's unheard of. So it means that people are spending less time in hospital. The average length of stay has come down considerably, and we're ensuring that there's good flow through the hospitals back into the community. So from our perspective, that's a significant achievement with great teamwork across the Health and Social Care Partnership and our acute colleagues. And I'd like to thank the work of Zoe Robertson, Amanda Taylor and Brian Kinnear and their teams in both PRI, the hospital discharge team, care at home services, and that whole system approach, which is supported through daily and weekly meetings So I'm really pleased to report that, and it really puts us in a very good position at this time of the year as we're heading into winter post Christmas. So and we hope that will continue to improve next week as we try to get people home for Christmas. So really pleased to provide that update to you. And I've seen Monica's nodding, so she might be able to say something of what that means from an acute perspective.
Thanks, Chief Officer. We spoke about this at our winter meeting. So there is a whole system winter meeting on a Wednesday morning, which all the partnerships as well as acute are represented at. We were just saying what a wonderful position PRI is in with 24 empty beds this morning, which is unheard of. And we were just congratulating the whole team in terms of how it's really been a whole system approach round about what's happening in acute, but also work with the partnership, particularly Zoe and Sharon working alongside them. And, there was really quite very positive noises coming out of the team this morning. I think we did have one diver on for about an hour or something, but I don't think it even got as far as people knowing about it, because we actually, it was 8 o'clock in the morning and we took it off as quick as it went on. So I don't think it was recorded, but yeah, and I think we sometimes forget, the impact that those diverts have, not only on the people of Perth and Kinross, but the rest of the people of Tayside and the staff in Ninewells, as well as the staff in Perth, because none of the staff in Perth want a divert to be on. They don't want their patients to be able to divert to Ninewells, but also in Ninewells, that increases corridor rates and everything across there as well. So it's amazing work that's been going on, and I think everybody's feeling the benefit, particularly as we're starting to see viruses rise, and we know nationally, well, Perth seems to be the only place so far we've not had an increase in flu. We're seeing it certainly in paediatrics, and in Ninewells we're starting to see that massive rise. Paediatrics have been very hot in the last 2 weeks, but yeah, congratulations to PRI and the work of the partnerships alongside them to get that.
It's helpful, I think, for the IGB to receive a report on what are the kind of what's the work that underpins that and the impact. So it'd be really good to see that at our next meeting. So we'll see what we can do about it. Yeah, great.
Dr. Peterson.
Yeah, it's just a quick query. I mean, that is brilliant and completely 100% agree. We can't have people in hospital. How are we gathering information from community staff to see the impact on them? And it's completely anecdotally, but I know sometimes we're finding that staff are coming into a supportive, quite rightly a supportive position for patients being discharged, but then it does decrease the resources that are available elsewhere. And I'm just wondering how we're monitoring to make sure that we don't have, for example, district nurse teams, AMP teams being stretched too lightly to be able to do this work, and just how we keep monitoring that side of things. So I'm not sure how that's done for a wider.
Yeah, absolutely. We have apologies today from Zoe Robertson, who has succumbed to one of the lethal winter viruses. So we'll pick that up with Zoe, but that's probably something we should capture in the report to the IGB the next time, so that you've got that wider perspective around the impact across the.
Because it's important we capture that in that whole system, that we capture the feelings of our community frontline staff, because it's brilliant that we're getting people out. There's not to take away from that at all. But what we don't want is for our frontline staff to be really feeling the pressure that they're feeling to support and divert resource elsewhere.
Thank you. Just picking up on Sal's point, I wonder if it would be possible, when we're looking at that, if we could kind of break down the impact of stopping admissions, because we always talk about delayed discharge and the initiatives around that. But I think we underestimate the amount of work in the community to stop these admissions happening. So if there was any way we could sort of break down not only the delayed discharge success, but and that reflects the work in the community of the amount of admissions that they're stopping coming into hospital at the beginning.
Thank you.
What's the impact of the frailty unit at PRI on that?
Sorry, I've seen the frailty unit. The way it works, it's just So, and you can correct me if I'm wrong, but having seen it from that point of view of going in, it's just such a phenomenal ethos in the fact they have a frailty unit, but they do still keep an eye on frailty patients elsewhere. You know, it's just, it really is that full multidisciplinary team, fully assessed, geriatrician to try and then remove them. That sounds awful, to discharge as soon as possible. So there's some brilliant work going on there, frailty, and also linking into community as well, which we're seeing more of. But yeah, it's great, there's stuff going on there.
Thank you. And did you want to come in, Dr. Dougal?
Yeah, I was just going to probably repeat what Sal's just said, actually, that the patients, as soon as they arrive, get to see a team who are expert in that particular area. What previously happened, probably they went in, they saw a generalist, and then they spent a couple of days, and then they would be seen by somebody's specialty. So it really makes a big difference, and the less time people are sitting in a bed on a general ward, the less deconditioning they're going to get, and they're going to be more functionally active when they get home. So it's really win-win. And we do have a great team up in PRI around that.
You want to come in on that point?
Yeah, it was just to say that there was a discussion at the Collaborative Response Assurance Group yesterday evening around frailty units, and that they're not universal across Scotland. So, and it's a fairly recent addition to Perth Royal Infirmary, but there's certainly an indication nationally that there's support for investing in that across Scotland, given the impact this has had, because I think it's Tayside and are the only health boards that have this.
Dr. Douglas, you wanted to come in?
Hello, sorry, apologies, I was unable to put my hand up. I just noticed that's not possible in the live meeting. But I think as well, it's just taking the opportunity, because a CMO letter did come out last week, again, just raising the importance of frontline health and social care workers, in particular having vaccinations. And there has been a drop this year in terms of uptake amongst health and social care workers. So I think it's just really pressing to push the opportunity at every point to promote vaccination again as a really effective way around reducing the severity and the transmission of the quademic, I think is what it's been framed as nationally. So yeah, that was the point I wanted to raise. Thank you.
Okay, and Amanda Taylor, you wanted to come in as well?
Thank you, Chair. I think just to advise that as part of the older people's paper, but there is a part around the frailty unit that gives some of the data around the frailty unit and the length of stay. So that has decreased greatly from 5.1 days to 2.4. So again, we're seeing a really big improvement around our frailty flow, and that's kind of supported by what the Chief Officer said around the delayed discharge position and our capacity and flow across the site. Thank you.
Thank you. I think that over 50% cut in length of stay sounds positive. Campbell, did you want to come in?
Yes, sorry, although my question kind of linked to Beth and Dr. Pearson maybe mentioned it, but it was in relation to admissions, so it's very positive, the delayed discharge and all of these people hopefully managing to get home, but it is about the support for them in the community, and of that, how do we know how many have been readmitted? I think that information is crucial.
I have a question, but I can also help answer the next question. So I was just looking at it up to the overall length of stay position for PRI is sitting at 4.1 days last week. And I think what Amanda was talking about was particularly the frailty unit. So what the frailty unit really does is try to prevent that deconditioning, because we know when we get particularly an older person into a bed, if they're in a bed for more than 24 hours, they start to decondition immediately. So that in itself results in increased resources, because if they're deconditioned, they need more rehab to get home, they need more services to get them home. So if we can maintain their independence when they very first come in the front door, make sure they get dressed every day, you know, that end that pyjama paralysis, all of those kind of things, and maintain their independence, then we really shorten the length of stay and we prevent them from losing independence. That's the whole ethos really around about the frailty units. So and there is tons of data on that we could bring back. You know, we've got really good data from 9 Miles over the last kind of 8 to 10 years. Over the last 2 years since we instituted it in Perth, there's that same improvement, like Amanda was saying. In terms of readmissions, we do look at all of our readmissions. The main problem we've got round about the national reporting of readmissions is that the data is, it's not even worth looking at because of the way they record it. So if you think about some of the other improvements we've made in PRI around about, for example, the ambulatory assessment area. So that's kind of, it's almost like a hot clinic area where primary care can refer patients up. We'll maybe see them, we'll do some bloods and we'll say, actually, right, you need a CT scan, but we can let you go home, you can come back tomorrow for the CT scan. That's classed as a readmission. It's not a readmission, it's a planned reattendance. So that totally skews our data and Tayside because of the way that it's set up. So we've been trying to look nationally, and I was working with, is it Chris Jolly? So him and I were doing some work around about how we monitor that and how we review our readmissions. So certainly in 9 Miles we look at them in a different way. So we were trying to institute that in PRI as well, where what we've got is we've got the real readmissions coming back in through the front door, and whether they're presenting to medicine or surgery or ED or wherever they're presenting to, if their CHI matches up. So to be fair, if you're readmitted within 7 days and your readmission rate in 28 days, there's virtually no difference. So we only look at 7 days rather than looking at 28-day readmission rates because there's hardly any difference. So looking at the 7-day readmission rate and matching up those CHIs of people who've been discharged and then come back within a week to any area of the hospital, and then going back in and looking at all of those individual cases. So we probably admit, in Tayside, we admit 2/3 of medical admissions to 9 Miles, about 1/3 to PRI out of our total number every day. So in 9 Miles, we probably have about 5 to 6 7-day admissions per week. We look at those every single week. So every Monday, there's an email comes out with all those lists, and there's the discharging consultant, the admitting consultant. They go in and look at every single one of those cases and determine whether it's avoidable or unavoidable. Instituting that in PRI as well, so that we're going back in and looking at those so that we can give an assurance that if there's something that we should have done the first time, that we learn from that and make sure it doesn't.
But I was just going to add to that as well. It's about as well, not about also about the readmission rates, but also about knowing the reason why, and that doesn't necessarily mean that it's medical. So one of the things I know that's been discussed, and Amanda will know about this, is this idea of delirium, and when the expectations of a family or even GPs or district nurse or what, when someone's been discharged with delirium and how long that might last and how long someone's supported, just because they're still, you know, confused doesn't necessarily mean they need to be readmitted. But there's also a wider piece of work around education and understanding the reasons why as well.
So,
I was just wondering about you were mentioning about the deconditioning that happens, and what I'm wondering about is the management of people who are using a wheelchair, because if they're taken in by ambulance, chairs like this can't go, and that means that they're then dependent on the hospital wheelchairs, where they can't even use those themselves. They have to be pushed. And there is an element, I think, of deconditioning there that can happen, and that if there is a way of avoiding using the ambulance, I know this sounds potentially risky, but of instead using the hospital access service, you know, who provide PAVs, a wheelchair access vehicle, so that their wheelchair could be brought, even if they can't use it themselves, somebody could be able to bring it to them. Because having that independence to promote, as you said, get up, get washed, get dressed, take yourself to the bathroom, you know, run your own little errands around the room. Things are quite helpful. I just wondered about asking if that could be looked at within the context of what you're doing.
I think certainly I'm happy to take it back in terms of secondary care representation. I think we would always encourage, whether it's an electric wheelchair or whether it's people's own aids that they use for mobility, we do encourage for those to be brought into the hospital. So they're using their own things that are, adjusted to each individual. Obviously, depending on the circumstances round about the admission, you may need a 999 ambulance, and there's not to do that. But we would certainly be encouraging people to bring in their own equipment so that they're able to do that. But I can certainly feed that back.
Thank you very much.
Okay. Thank you. I think if we're getting a report, in the future, we need to draw that discussion to close there. Are there any other questions, verbal questions for the Chief Officer? Or can we move on to the next item on the agenda? Thank you very much, which is the Tayside Mental Health and Learning Disability Services strategic update. This is a report by our Chief Officer, but we also have online Sandra McLeod, who is the Deputy Chief Executive of NHS Tayside and the Executive Lead for Mental Health. So welcome to you online, Sandra. Chief Officer, if you'd like to introduce the paper.
Thank you very much, Chair. I'll just give a very brief update, introduction. Because this report updates the Integration Joint Board on the work taken forward since our last report in October, the 2nd of October, and covers progress to middle of November, when was the last meeting of the programme board, which was a meeting dedicated to reviewing all of the work streams across the programme and the priorities that underpin that. And it's a very detailed assessment of progress presented to the board, along with recommendations about the work streams and the extent to which the programme could be further refined, or where those areas could be continued within a cycle of ongoing improvement, and continue to be embedded by operational leads and managers in everyday activity. The outcomes and agreements from that meeting are set out in Appendix 1. And the agreed approach is to bring together the work streams that are not yet complete into two main areas of focus, which are the model of care for mental health and the model of care for learning disability services. And that's set out for you in a diagrammatic form in the papers. And it was also noted in the report that there was intended to be a celebration event, which was held yesterday in partnership with staff at the V&A Museum in Dundee. The theme of the day was connection, collaboration, and culture featured highly across the whole agenda. And yesterday there was evidence of a positive step forward in how we're working together across a wide range of stakeholders on this whole agenda, and clear indications that there has been a significant shift over the last year to 18 months. A report will be prepared on that day because it was constructed in a way to be able to provide both qualitative and quantitative evaluation of the impact of the design approach across the programme. And in this report, the IGB is also asked to note the first quarterly report of the work of the Task and Finish group, which is leading on the relocation of inpatient learning disability services as part of the NHS Tayside operational plan to relocate services to Murray Royal Hospital. And as the Chief has indicated, Sandra McLeod is ongoing in her role with responsibility for inpatient mental health and learning disabilities services. And I don't know if Sandra would want to say anything by way of introduction to your report.
Thank you, Jackie. Thank you, Chair. The report in the appendix, I would hope, is comprehensive for colleagues. It goes through each of the recommendations, highlights progress, and also explains the setup and function of the Task and Finish group, but more than happy to answer any questions from the board.
Thank you both. Do we have any questions on this report, or any comments on the report? We'll come to Maureen first.
Is it still on target to be completed by August 25.
Sandra?
Yep, thank you, Chair. The target of August 25, so some of the work that is required for the move, particularly from patients from Strathmartin into Murray Royal, given the length of, I'm sure people will be aware, there is still a significant level of delays across the system, less so than Perth and Kinross, but definitely across the other partnerships. So there is a need for us to redesign some of the buildings within Murray Royal to accommodate the increased needs. So we've worked closely with our clinicians and with our estates team for them to do that and redesign into enhanced care centres. We had the final plans that the clinicians signed off with the architects last week. So what happens now is we get those plans drawn up, we share them with the contractor who'll be doing the work, and then we'll get a time frame exactly for the move for the Strathmartin patients moving to Murray Royal. In the meantime, we are looking at alternatives, because you will be, not alternatives for them, but how we can start to progress the move from LADU, from Carsview to Murray Royal, and also how we can accommodate other opportunities that are there to help us meet the requirements that have been with us for some time about single sites. So I suppose in answer to your question, that is definitely our ambition. The thing that will stop that ambition or hold it up will be the when we get final date of completion expected on the work that has to be done to ensure the accommodation is suitable. Hopefully that helps.
Thank you. Dr. Peterson.
Yeah, it's just a quick query, because obviously this is great work with the redesign and looking at the new model. My question was almost like, while this is being undertaken, is there improvement work going on for waiting lists? I think I've read this correct. There's nearly 4,000 patients on the waiting list, and we've got a huge amount that are waiting over a year. Now, having spoken to some of my other colleagues who are involved with redesign elsewhere, they're almost tackling it twofold in the fact we've got all the redesign work going on and the changing of pathways, etc. But they're also making sure that they're putting something in place to decrease those waiting lists and make sure that those patients are being cared for in the meantime. And I wonder if you knew of any work that was happening for these patients at the moment.
There's certainly work carried out in Angus around that, and that was considered nationally. But one of the things I think what we need to do is think about what does this model of care look like for Perth and Kinross. And I know we've got a local community update here, and I know Jane in her new role within the Health and Social Care Partnership is beginning to have these discussions locally.
Because I think probably one of the reasons why I've got an interest as a GP is that we talk a lot in these discussions about GP access, and it comes out in surveys, and it comes out understandably so by our, carers and things. But while we have such long waiting lists in fundamental areas such as mental health, those patients are consulting with us, which means that we can't have enough time to deal with us. I think we have to recognise that impact on GPs while we've got such long waiting lists. So it'd be really great if we could know that there was some work going on to improve that as well.
Thanks. And Sandra McLeod, you wanted to come in?
Yeah, just to provide assurance, the work that's happening through the whole system change programme on the model of care redesign is fundamentally looking at how we deliver our services in a much more place-based approach, linking in the MDT through all levels of that model of care. So there is work at the moment that's ongoing, engaging with both the cluster leads, I think GP sub through the area clinical forums to make sure we have that engagement, and there will be further events across January as the model of care is developed. But that's exactly what you're saying, is not only are we doing the work that's on about the building, it's not all about bricks and mortar, it's about how do we create and look at our community services, and the overarching model of care is about really having well bedded in services within a local level, but also having access to that specialist care when it's needed. So you should have, and hopefully will have, engagement, or at least start to hear about the model of care, but happy to pick up anything with that offline if that would be helpful.
Thanks very much. Councillor Illingworth.
I was going to ask the same question as Maureen, so she beat me to it. Right.
Have we got any more questions on Mr. Black?
Thanks. Thanks. So page 6 of 11, so 82 of 272, and it's integrated substance use and mental health, and it's about the workforce and development plan, and we intend to merge outstanding work with the moral care and transition. Is there a timescale for that?
Like Sandra, I'm not sure that there's a time scale. There's certainly not set out in this report, but the detailed recommendation that came to the programme board would have given an indication, and I don't have that to hand, but what I will do is find out for you.
Okay.
Thank you. Any more? Oh, Sandra, sorry. Yep.
Thank you very much. A couple of questions. I noted within the report, and Chief Officer also mentioned it, that there had been consultation with a wide range of stakeholders. I, on reading the report, which is really comprehensive, and thank you for that, it would be helpful in reports of this type where such engagement has taken place, if we could be given a kind of outline of who those stakeholders are. I don't mean necessarily people's names, but what groups of stakeholders had been engaged with, just to give us a little bit more insight and a wee bit more granularity into that. And the other thing I wanted to ask about, there are several, while appreciating that the IGB doesn't have responsibility for children's services and children CAMs, there are quite a few references in this report about the interaction with the CAMs service. And I think I'm correct in saying that there has been a change quite recently regarding referrals to CAMs, where referrals will no longer be taken unless there is multiple morbidity. So referrals for ADHD or autism, if they are just single issues, won't be taken. And I think the expectation is that that will have quite an impact on services generally. And I wondered if the potential impact of that has been built into to this report. Thank you.
Could I just come in there, because probably I know a bit about it. So the stuff that had come out from CAMS was a communication issue rather than it actually being the criteria that was used. It's been addressed by both the LMC and the GP sub, and there are ongoing discussions with the CAMS service, and certainly I was at the Realistic Medicine conference, which actually stops, which CAMS were there for, and I don't think it's that they're not accepting referrals. I think there's very much a collaborative approach also with education to move that what is needed in medical model compared to the newer, more social, educational type model. So there's works going on in both spheres to try and accommodate it. Does that make sense? That's how I understood it anyway.
Can I come back on that then? If so, thank you very much for that explanation. If that in fact is the case, having spoken to colleagues in education again really recently this week, then I think there is some substantial and significant misunderstanding from the education perspective as well. So that might be something that would be worthwhile investigating and maybe looking into a little bit further. Thank you. Although, as I say, I appreciate that this isn't a specific remit for us, for the IGB, but the knock-on impact of CAM services, as we've discussed many times before, is significant. Thank you.
Want to come in at this point, Dr. Dodd?
Yeah, so I'm going to make a declaration of interest. I am the Associate Medical Director that manages CAMS. I can assure you that there is collaborative work going on with the TRIC group, which includes the directors of education, the directors of sort of the head social worker in each of the 3 local authority areas, along with the CAM service and their chief executive, about how we manage that service. But that's probably as much as I can.
And for everybody's benefit, TRIC is the Tayside Regional Improvement Collaborative.
Sorry.
Which is a sort of bringing together 3 local authorities. NHS Tayside.
So we've got education, social work, police and health all at that.
And Chief Officer, you wanted to come back on the point about the stakeholder engagement.
Yes, Sandra, thanks very much for raising that, because I think in previous presentations and in reports to the IJB, we've tried to demonstrate how we've included people with lived experience, advocates and advocacy organisations throughout the programme, so that it's not a separate group of people, that what we have are people integrated into the work that's going on. One of the areas of redesign that came from the work with the V&A around design thinking was the sharing care together work. They presented yesterday on the where they are with their I don't want to call it a project because it's much bigger than that, and they've really taken the whole idea forward, and the momentum is building. And they're ready and seeking funding to build a website which will give accessibility for anyone who wants to engage with that forum to provide feedback of their experiences around mental health and learning disability services. So it's on the cusp of something quite special, I think. So we'll make sure that there's a bit more detail available to you in our future reports.
Thank you. Yes, somebody's got another question?
Well, I just, what's happening about the staff who aren't happy about moving, with the LD. We had somebody in the union, 2 or 3 meetings ago, telling us that the staff, some of them weren't prepared to move. And this was upsetting families because, the patients get familiar with the staff, and it's going to cause a lot of upset. And some of the families aren't happy anyway about the forced move to Murray Royal, so I just wondered what's being done to support the families, and also what the update is with staffing.
Sandra McLeod?
Yes, certainly I can update. All the staff are having one-to-one meetings with the general manager for us to get an understanding of those staff. There's about 100 staff that will be impacted. To understand those staff who are able to move, those that would choose not to move, and those that for personal circumstances can't move. Once we have that data and understanding, and we have the date, then we'll be able to then start to put in clear plans. I absolutely understand the concerns that both staff have raised and families have raised about how well people get to know their patients. But what I would, and hopefully Jackie may well come in on some support with this, but the key thing about our learning disabilities, it's not a long-term unit. It's never designed to be that. And the reason that we have delays is because there hasn't been the facilities within the community environment for people to be discharged. The ultimate aim for all learning disability services is that there is community support available and that community resources are available so that people do not spend many years of their life in hospital. As such, when anybody is moving, there's a significant transition plan that gets put in place that helps people adapt both to their new environment and to their new staff teams. Once we have the dates for moving and we understand the impact that will be on staff, it may well be that we need to go out and recruit more staff, while those staff that choose not to move go through our agreed processes on organisational change. But ultimately, the environment has been clarified on numerous occasions at Strathmartin is not fit for purpose. And I think that there is that need to move, and we've had significant recommendations across the years from both Strang and the Independent Oversight Group that decisions require to be made on the moves. So that's actually what we're undertaking. We do firmly acknowledge the impact this will have there, but if we were to look further down the line, and as with any patient who's been discharged from a learning disability unit, the longer transition plans are required to help them move forward, and that's just, we will apply that exact same process. With regards to families and carers we have been engaging, there's advocacy services, and we do have a work stream that's specifically focused on understanding the concerns of families. And so hopefully that answers the question there, Maureen.
Okay, thank you.
And Lindsay Hunter, you wanted to come in with a comment at this point?
Hi everybody, my name's Lindsay Hunter. I'm staff side for NHS Tayside and a lead for Perth and Kinross Health and Social Care Partnership. So Maureen, it was myself that you were alluding to that came and read out the statement. It's just on the back of what Sandra has said. I agree with what she's saying as far as I am aware. Now, the reason I'm saying that is because I actually don't have members within this area, as I am a podiatrist to trade and my union is Royal College of Podiatry. So we don't have podiatrists within this area. However, my colleagues are involved within the organisational change process, which would happen to any staff member within NHS Tayside that something like this is happening to. As far as I am aware, that is the one-to-ones are happening, but as you can hear, Sandra, there's a lot of people to go through this, so that's going to take time as well. There's also a lot of work streams through NHS Tayside that are happening. I am part of the communications work stream and they are communicating with staff and patients as sort of have like a one place, so it's not Chinese whispers, it's coming out from one area. So I hope that kind of helps with your question, Maureen, but as far as I am aware, the policies are being adhered to.
Okay, thanks very much. Are there any other questions? I've got one. Okay, I'll go for mine then. In the appendix, which is talking about the continued refinement and focus of the change programme and its work streams, and figure 3, summary of decisions by the programme board in November. There's a column on the right which is talking about whether any of the work streams are to be retained in the programme. For those where that's not ticked, presumably these are being removed from the programme, and I just wondered what the sort of residual scrutiny function for either NHS Tayside board, but more specifically the Integration Joint Board is over the inpatient mental health and learning disability.
Thanks for that question, Chair, and sorry if that was not clear in the report. There are comments in that final column, so that was where the programme board was seeking further assurance about the extent to which progress had made before they were prepared to say that that's a job done and move into business as usual and the cycle. So you'll see there that's a request for various parts of the programme to come forward to future meetings of the programme board and a timescale set aside each of those. And that was because they were looking for a final report or a further piece of evaluation work in each of those. Thanks.
Thank you. Okay, so there's no other questions or comments on the report. Can we note the updated position and detailed progress update on mental health and learning disabilities full system change programme? Can we approve the refined priorities for the programmes as set out in Appendix 1 and note the first quarterly update report of the task and finish group in relation to the inpatient learning disability services? Is that agreed? Agreed. Thank you very much. And thank you very much, Sandra, for your attendance online. Thank you. Appreciated. We will move on to carrying on the mental health theme. I think we'll take the annual update on community mental health and wellbeing strategy, and then we'll take a break after that. It should be about maybe sort of 90 minutes in, so we'll stretch our legs at that point before completing the agenda. This item, the annual update on the community mental health and wellbeing strategy, is going to be introduced by Chris Lamont, and I believe Chris is going to do that by means of a presentation, I think. Chris, over to you.
Thank you, Chair. Yeah, I don't know if you can see the presentation, but hopefully somebody's put it up on the board for you.
We're just bringing it up, Chris. Thanks.
No problem at all. I'll just wait for 2 seconds. Just also to let everybody know that I am actually currently paying homage to Val Doonican, hence my background.
Thank you. We've got it now, Chris.
You're very welcome. Okay, so I'll just make a restart if that's okay. So, as some people on the call will be aware, I've been coming here now for the last 3 years, giving an annual update on our local community mental health and wellbeing strategy. Our strategy is actually coming now into its final, well, it's just entered its final year now, and it'll be getting updated early part of next year, and at some point next year we will then be bringing a new strategic plan to the IJB for sign-off. So this is currently now an update on the progress that we've made over the final year of our strategy. So I'll just carry on just now. So next slide, please. The recommendation that I've brought is around just obviously noting our local developments that have been progressed over the past year, also to acknowledge the numerous and complex factors around how we can progress this work, and some of which has already just been aired and discussed in the previous conversation, and also hopefully to support the development of a revised strategic plan going forward next year. Next slide, please. Our strategy covered 5 key themes. I'm not going to read into all of them, but as you can see here, it was around early intervention, access to services, a coordinated approach, participation and engagement, and a review of workforce requirements. We did and still do, although it's been a state of abeyance at this moment in time, we did have a strategic mental health group that met on a monthly basis. That was put on hold around about August of this year, purely and simply because of the Tayside-wide work that was taking place, and many members of that strategic group were actually involved in that on a Tayside-wide basis. So we thought that there was an awful lot of duplication going on at that moment in time, and we stood the group down on a temporary basis. That group will start again next year when we start looking at the new iteration of the strategy. Next slide, please. So this really just gives a very brief overview of how we look at our strategic aims from a mental health perspective on a localised basis across P&K. As you can see here from the Scottish Government guidelines, we should be taking into cognisance environmental, physical, social, emotional, etc. Situations that individuals bring. And obviously, if any one of these are out of kilter, then that increases the risk of an individual developing a mental ill health. If there's more than one, then usually that can have repercussions around significant mental ill health issues. And these are the reasons why we want to make sure that all of these are encompassed with whatever we try and deliver. Next slide, please. This slide just gives a very brief overview of what our current statutory services are delivering on. As you can see, at any given time, we're seeing approximately 5,000 people across P&K. There is a significant breakdown on this that you can also drill down into. The 2,694 is under the primary care, is under adult community mental health teams. So they are the significant service that sees the majority of individuals. What we have discovered is, and it's already been touched on, I think it was from Dr. Peterson touched on this, that although our CMHTs currently see the majority of individuals with mental illness or mental ill health difficulties, not everyone that's currently being seen through our CMHTs fits the criteria for being seen by them. And our community mental health teams are actually set up for dealing with individuals with complex care needs. And there's a significant proportion of individuals that are now being seen through our community mental health teams that don't fit that criteria. And what we need to do is moving forward into the next iteration of our strategy, which also ties in with the model of care ethos, is to look at how best we can utilise other services to allow individuals to access mental health services on a more timely manner and ensure that they don't fall down the gaps. Next slide, please. This is what we term as our burden of disease mental health data. There's a breakdown of this more succinct within the report. However, as you can see here, this basically looks at all the different categories of what we would term from a mental health and substance use perspective across P&K. What we do is we collectively look at the overall years that are lost to mental ill health across our population. And as you can see here, the largest one from a loss of time is depression. Interestingly, we are about 12% lower than the overall Scottish average, but it is still the highest number that we see through P&K, and I'm sure that my primary care colleagues will be able to recognise that. Also, second in line is around anxiety and associated disorders, when you look at that from an ill health perspective, and then obviously from a substance use perspective, the numbers of years lost are significantly high as well. Next slide, please. So the progress to date, just to give a very brief update around all of this, is over the last year is we are currently undertaking a transformation programme around primary care mental health. This is a Scottish Government initiative, but it also ties very succinctly in with the model of care. The ethos around all of this is that individuals should be able to access mental health services, whether or not they are statutory or third sector or voluntary services at any given time. We are currently looking and exploring how we can have a single point of contact for individuals to access the services, but also, and more importantly, referring back to slides, it's around ensuring that the most appropriate service is being utilised and accessed, because some people are being parachuted into services that are just not appropriate for their needs at all, and hence the reason why we're working in a lot of collaborative work just at this moment in time with third sector colleagues. We also have devised a suicide prevention and awareness strategy, which is going to the Chief Officers Group in next week, I believe it is, for sign off. I'm happy to report, albeit it's still sad news when any death is recorded, but in 2023 we had 18 suicide deaths, which is the lowest that we've ever recorded in Perth and Kinross. The year prior to that we had 35. I've received a recent update from our Suicide Awareness and Prevention Coordinator, and at this moment in time, on a calendar year, we look like we are roughly at round about the same number as 18 as we were last year. So that seems to be a consistent number that we've dropped down from. We're not entirely sure the reasons around that. There has been an awful lot of developmental work involving the police, crews, third sector organisations like the NUC. So we think it's probably a joint amount of work that's come together, and hopefully that will be sustained. Delayed discharges have already been touched on by the Chief Officer. We have been regularly low in our inpatient wards at Murray Royal Hospital, particularly from an acute adult perspective. At any given time, we've usually got 1 or 2 delayed discharges within the Morden unit or Carstview. Sandra also touched on earlier around our learning disability client group. I think we've currently got 3 sitting at Strathmartin, which is still low, and we're making inroads into getting those individuals back out into the community. Our POA discharges have gone up slightly over the last couple of months. We are doing some active work around trying to get those dropped down. Sorry, for those that aren't familiar with POA, that's psychiatry of old age. And the predominant reason for that is because there are unsuitable locations for individuals to be discharged into within Perth and Kinross due to their complex needs. We have also delivered our very first mental health and wellbeing conference, and I'm aware that some people in the room and on the line will have attended this. This took place in May of this year down at the concert hall. There was about 240 delegates that attended, a variety of different stalls. We had guest speakers that came, and the main ethos of the conference was around connectivity and utilising different services to have all of the same aim and the same goal. 2 weeks ago, we had a follow-up event on the Murray Royal site known as November. It was not a homage to Noel Edmonds. It was about Noel, as in Christmas. And again, it was a mental health and wellbeing event that was very well attended, and it was for service users, carers and service providers. We have developed a neurodevelopmental pathway, and we've actually employed a specialist neurodevelopmental nurse that is now fully embedded within our services and is tackling the extensive waiting list that we'd already developed, we'd already built up across Perth and Kinross, which was sitting at around about 400 individuals. This individual, who I am not ashamed to say we stole from CAMS and came with excellent knowledge and expertise, is currently helping to develop training packages as well across our adult community mental health teams as well, so that we are developing this on a more robust and longevity model. And we have also developed a clinical pharmacy model, which I know that the clinical lead for pharmacy across Tayside has been heavily involved with, and this is around about embedding pharmacists within our community mental health teams to make sure that prescribing ethos is robustly being maintained and helping individuals to have the medication reviewed on a timely basis. Next slide, please. So we are also from an ECT and therapeutics service, which comes under our banner. We have received again our accredited award this year, and the ECT and therapeutics service at Murray Royal has been put forward for a national award. We are also looking from a therapeutics service perspective at how we can embed this more closely and align it with our community mental health teams out within the community, so not individuals don't have to keep all traipsing up to Murray Royal and access the service there. We have developed and fully embedded now a clinical care governance forum, which our lead nurse and our prior lead AHP were heavily involved in. And this is very well attended, meets on a 6-weekly basis, and we look at exception reports. There is around a whole system programme of events, so it looks at all aspects of mental health, learning disability and substance use, and we take forward any areas that require to be progressed regarding risks or areas of good practice. And I'm also pleased to announce that we've had 3 separate services within mental health that have all been put forward for the NHS Tayside Star Awards this year. System-wide collegiate working and support. This makes reference to obviously all the ongoing work that we're currently doing with our third sector colleagues. And again, tying this in with the distress brief interventions, I'm pleased to announce that one of our local third sector providers has recently been awarded the commission contract for delivering distress brief interventions across Perth and Kinross. And finally, our workforce development, although this is also under challenges, which I'll come on to just in a second, this is to highlight the good work that we've been able to sustain around reducing our vacancy factors across our services and helping to bring in newly qualified mental health nurses at quite a high level. Next slide, please. So the key challenges, as I've just mentioned, recruitment and retention of staff. There was recent information that was provided to us by NHS Tayside, and it was in regards to adult mental health nurses across the whole of Tayside, including community mental health, substance use and learning disabilities. And out of approximately 1,200 staff, over 700 of those staff were over the age of 50, which equates to around about 60%. Coupled with the fact that we know nationally there has been a 20% reduction in student nurse uptake at universities, potentially over the next 3 to 5 years, we could be heading towards a significant staffing challenge across all aspects of mental health across the whole of Scotland. So it's something that we need to keep on our radar. Obviously, we've got winter pressures. There's already been mention of the quademic, which I only actually heard first thing this morning on the news. Didn't even know what it was. I thought it was a new form of car or something like that. But there is increased demand, and we are noticing that this increased demand continues throughout the whole of the year and doesn't necessarily just kick in at winter. There is the mental health, drug and alcohol comorbidities, which we are actually working quite well on, but I have put this down as a challenge because for those on the call will recognise we have the 10 MAT standards, which are the treatment standards around alcohol and substance use. We are doing very well in P&K, apart from one of the standards, which seems to be on a national basis, nobody's attaining it, and that is around primary care prescribing and that intervention coming from a primary care perspective. And I know that there's a lot of work taking place just now to address that. We do have on the 28th of January a workshop specifically within P&K to look at how we can have a multi-agency consultation around developing joint working with individuals who have comorbidity between alcohol and mental health, alcohol, drug and mental health issues. And that is something that's been taken forward by one of my service managers. And obviously there's the future financial challenges and current financial challenges, which I'm aware that there's a paper coming shortly on the agenda as well. Next slide, please. So in conclusion, this is just to look at the continued progress throughout, I should say, third year of the delivery plan. This is in no small part, as I've already mentioned, around the joint work and the collegiate working with our third sector colleagues, because I don't think we'd be able to deliver half of what we have done without this. And I do have, at this moment in time, do have to make recognition towards the work that has been delivered by all of our services, both statutory and third sector. They've worked their socks off over this last year. The next 12 months is obviously going to see the development of our primary care mental health provision, which is a core part of the whole model of care, but also driving forward our next iteration of the strategic plan. And also it's also just to take cognizance as well that Jane, who's in the room, and Zoe, who's not present today, have recently been brought in as our heads of service, and will obviously be driving forward around focused work and integration of our services. Thank you.
Thank you very much, Chris. We've got any questions or comments? Oh, Martin, sorry.
Right, thanks very much for your presentation, much appreciated. And it's really encouraging. I'm the alcohol and drug champion for an NHS Tayside, and it's encouraging to actually start to see that this recognition of the link between mental health and substance use has been recognised here, and that you are going to put that conference on. I look forward to hearing all about it.
Thank you, Martin. I don't know if you've received an invite, but you're more than welcome to go up and visit the team that have recently moved into the Burnham Day Centre on the Murray Royal site. If you haven't managed to go up, I'd be more than happy to try and arrange you to go up and have a walk around and meet with some of the staff.
We haven't
We've not been to the new place, but we did meet some of the staff previously, Beth and myself, and that's encouraging. Ahead of the game. The only problem I do have is match standard, but that's again, that's just my own.
Is that with the standards rather than with their performance? I'm not asking.
Okay, have we got any other questions or comments from the board?
Just for the purpose of the minutes, it was just to congratulate Chris and his staff and everybody that's been involved just in the work that was carried out. I've particularly enjoyed the conference in May. Can't believe it was May. I was trying to think when we were going to have the next one. Are you going to make it an annual event, Chris? It was most enjoyable.
I'd love to, Beth. I'm not sure if the finances will stretch that far. I might have to go out with my sandwich board and start begging.
It was very good, and you're beginning to see all the things coming through. So I'm particularly impressed with the suicide statistics. That's quite a drop from mid-30s to 18 consistently over 2 years. So it's good to see these things coming through. I wanted to note that appreciation to all the staff involved.
Thank you.
Yeah, I was just going to make the point that I don't think the finances should stop the opportunity for services to come together and connect and celebrate what's going on. But I think the timing of this is really important because the model of care that we've spoken about in the previous paper and how we will apply that here in Perth and Kinross, that engagement around that. So that coming together, that really has to be a focus of what does that mean. And I know, Jane, you attended the strategic planning group and had a discussion around that. So expect to see much more around what will this look like in Perth and Kinross in terms of our application and level of care. So I can see something. Chris going away with an action around. We must have a conference, even if it doesn't cost us very much.
It doesn't need to be up in the
We must have
venue.
something around Wadlock here.
Is he still alive?
Okay. Did you interest?
Well, Duncan alive for days.
No, he's away.
He's away. All right. Thank you.
I was just wondering, just thinking about it, just about how you plan to link in, obviously, with general practice. So I think recent statistics shows that about 40% of all consultations within primary care have actually got a mental health aspect, which is a huge number. I think I worked out that would be about 15,000 consults per month in P&K, which have a mental health. So I'd be interested to know how you're going to, what your plans are to work with primary care, to engage with primary care. Well, not primary care actually, no, because you're using primary care with general practice, because obviously they are the people that are seeing most of the mental health in Perth and Kinross.
Yeah, no, absolutely. So as again, Sally, you'll be aware, and some people on the call will be aware, we have a lead GP for mental health that's aligned to the partnership, Dr. Kirsten McInnes. So Kirsten's been meeting regularly with myself and other members of the management team around how we can start developing primary care, the integration within GP surgeries, how we can develop referral pathways. And I'm aware that Kirsten, I think, is tying in with the other two GP links with Cross Tayside, Nadine, I can't remember her surname, in Dundee, and her counterpart in Angus. And I think that between all of us, and what's happening through the model of care, I think that there'll then be some communication going out. I think that Sandra's already alluded as well to the fact that I think Dr. Lefebvre, who's our Associate Medical Director for Mental Health, he's been going out and meeting with a variety of different organisations and professions, and I think he's currently in the process of arranging meetings with GP leads, etc., around how all of this is going to tie in. Ideally, we would like to develop some form of a referral pathway, which would be very simple, very easy to access, and individuals could just then be referred into, as Dr. Dougal on the call has referred previously to, a hopper system where people can just get referred in and then they get filtered down into the most relevant areas. And that way it would then save individuals from bouncing backwards and forwards between GPs and secondary services and never being actually picked up. So that would be the ideal plan. And I know that, like I say, Dr. Kirsten McInnes has been involved through a lot of this, so that's how we will be interfacing with the GPs.
Thank you very much. I'm not seeing any further requests for questions or comments. So thank you very much for the presentation and the update on the mental health and wellbeing strategy. Chris, can I invite the board to note the local and Tayside developments that are being progressed in accordance with our current community mental health and wellbeing strategy. Acknowledge the numerous and complex factors influencing this work and support the development of the revised strategic plan due for completion in 2025. Thank you very much. So that concludes that item on the agenda. It is 3:35. So can we take a 10-minute break and be back at 3:45? Thanks very much all. Thank you. We'll now move on to item 7.5 on the agenda, which is the progress against our older people's strategic delivery plan. It was going to be Zero Robertson, but we've heard she's had to put in her apologies, so it's going to be introduced instead by Amanda Taylor. Amanda, over to you.
Thank you, Chair. And as you've said, I'm stepping in for Zoe, so apologies. We'll just be talking to the paper that's in your pack in front of you, so hopefully that'll be sufficient, and I'll just run through that with you. The purpose of the report is to provide the IGB with an update on the progress against all the programmes of work described in the Older People's Strategic Delivery Plan 2022 to 25 as the plan comes to the end of its strategic life cycle. It's recommended that the Integrated Joint Board note the significant progress against all programmes of work outlined in and funded under the Plan 2022 to 25, and endorses the intention to refresh the plan to align with the IGB Strategic Plan 2024 to 27 and to take a longer term approach in how we plan for older people's services by the introduction of a 10-year Ageing Well strategy. The Older People's Strategic Delivery Plan was agreed by the IGB in March 2022 against a backdrop of ongoing COVID-19 and the beginnings of a post-pandemic recovery work. A significant level of funding was allocated within year one of the plan to support achievement of the objectives contained, and progress against these has been reported to the IGB on an annual basis. Over the course of the second and third years of the plan, a changing and increasingly challenging financial landscape, a rising elderly demographic presenting with more complex long-term health conditions and comorbidities, alongside ongoing recruitment and retention issues, have necessitated the adaptation of some of the planned programmes of work to achieve sustainability of our service provision. A key element within this work has been the partnership's continued progress towards whole system integration, allowing staff to work in a more sustainable, coordinated and patient-centred way. The increasing proportion of our local population aged 65 or older is well known and well documented, and the prevalence of long-term health conditions among this population and the impact of this have on the health and well-being of older people is also well understood. Despite the challenges, considerable progress has been made towards achieving the IGB's strategic plan. As part of the programmes of works to embed these strategic ambitions into everyday practice, we were organised into three distinct themes: early intervention and prevention, shifting the balance of care, and optimising capacity and flow. The paper here today will focus on later phase 2 actions of our plan and those either completed or in progress of part of phase 3 work and ongoing transformation programmes outlined in the IGB strategic plan. As part of the work undertaken in phase 2, as work stream 1, we've focused on an early intervention approach, as we've already mentioned, and that's really looking at integrated working, how we've supported care home residents and staff, improving access to and participation in physical activity for older people, reducing social isolation, developing the third sector contribution, promoting age-friendly communities, and supporting older people at risk of fuel poverty. As part of our integrated approach, we've continued to work with key stakeholders to further strengthen our alliances with community, third and independent sector partners, while we've tried to embed the adoption of healthy lifestyle choices to support continued physical well-being into older age. This is a core group of people, and we're hopeful that this group will move forward into the membership of our age-friendly board going forward. We've continued to support the Going for Gold programme for care home residents, and a short life working group was set up to support the transfer of ownership of Going for Gold to the Care Home Activity Network, our independent sector lead and Live Active Leisure colleagues. Also, as part of our work in 2023, our What Matters to You programme gave care home staff the opportunity to come together with our public sector colleagues across the partnership to share experiences, successes, challenges and good practice. 4 What Matter to You events were progressed with 140 care home staff able to participate, and from that we've developed a network of attendees who signed up as What Matter to You ambassadors. And you'll see in your paper that we've embedded the Celebrating People, the output from all those events for your information. As part of this work stream, the Enhanced Care Home team, which is funded in the majority by the Non-Recurring Care Home Collaborative Fund of the Scottish Government, continue to support and mentor care home managers to deliver sustained, high-quality improvements in care provision and person-centred care delivery. It also allowed access to staff training and support, and currently the model has been reviewed across Tayside at the end of 2023, and information is currently waited from Scottish Government regarding ongoing funding. The Care About Physical Activity model, which many of you will be aware of, is now in place across health and social care services, including our inpatient settings, care homes, care at home, heart service, sheltered housing, unpaid carers and prisoner healthcare, and is seen as a core part of our everyday work now. Alongside this, the Paths for All, Walking with Strength and Balance resources are now embedded as business as usual, there is information available for any areas that haven't got this in place that we can embed this locally. Dementia-friendly walking routes have been delivered in Blairgowrie and Crieff Community Hospitals, Tay Ward, PRI and Murray Royal. And again, for areas that don't have this in place, the information is available to embed this and is now seen as our business as usual. Work has also continued to fully establish and embed the pathway implemented by Live Active Leisure to support people to move from one-to-one physical activity support at home towards accessing other suitable activity opportunities within their local communities. The Community Circles Coordinator post, which has been described in previous papers, has been in post since April 2022. And this has allowed us to recruit volunteers to be the lead person of potential friends, family and neighbours who would be available to support and help vulnerable family members and friends. Currently, we have 26 volunteers spread over Perth and Kinross who are supporting this approach within daycare services, care homes and the community hospitals and communities in a range of befriending, activity and buddy roles. Alzheimer's Scotland has developed a brain health and dementia resource centre in Perth, which also provides advice and support pre and post diagnosis for people living with dementia and their family and carers. And we continue to explore the option of a more enhanced brain health hub approach. Alzheimer's Scotland also had a year-long pilot where they delivered 2 weekly therapeutic groups within North Perthshire at the Tryst in Pitlochry, and they are currently supporting 9 individuals with dementia. This pilot has replaced an existing, although declining, service. However, they have put in an improvement process to review the referral process, increase numbers in attendance, and successfully working in partnership with Heart for Art and Live Active Leisure. As many of you will know, Perth and Kinross Council achieved accreditation in the UK Friendly Cities Network as part of the World Health Organization Global Network of Age-Friendly Cities and Communities, and many events have taken place to help build the age-friendly communities approach across a range of partnership and council work streams. In October, through strong links with community partners, we've put together a calendar of events to celebrate the contribution older people make to their communities. Workshops have also been undertaken in collaboration with the Community Planning Partnership to consider the best ways to tackle fuel poverty, and a Winter Fuel Poverty Fund was established and supported by the partnership. Fuel poverty, as you many will know, sits in the main with the Community Planning Partnership, while we are seen as a partnership and a partner within this approach. Within our workstream 2, shifting the balanced care, the actions that were outstanding were in relation to the community alarm capacity and implementation of digital telecare and developing a sustainable model for our medicine for the elderly community hospital services. As part of our community alarm capacity, the services are now in a position where they have adequate resources to deal with increased call volumes and call outs and are able to meet the TSA standards for call handling. Services are now able to meet safe staffing levels, improving staff morale and welfare, and are in a position to support and adopt other essential functions such as CCTV management, telehealth, call monitoring, and response and investigation and delivery of hosted calls. As part of their approach, a further improvement includes an overnight responder service, Test of Change, which was implemented in January 2024. And this is a joint piece of work with Com Alarms team, Supported Living team at St Catherine's Road, Technology and Enhanced Caring team and Social Work. The aim was delivery of a virtual night support via community alarm and what we call COMP, and that link is in your paper as well should people wish to have a further look. Our medicine for the elderly support has been reviewed and as part of our clinical approach to supporting Blairgowrie, Crieff, Pitlochry and St Margaret's community hospitals, and a workforce review is underway and is now moving into a business as usual approach. As part of our work stream 3, optimising capacity and flow, some of you've heard from the Chief Officer update this morning, and we've implemented the recommendations from Discharge Without Delay strategy. And this has really looked at implementation of what we call planned date of discharge, a home first approach. We've already discussed the huge improvements we've seen in length of stay across our partnership wards and acute services, and our discharge pathways across the health and social care sites. We've improved the patient journey from admission to discharge, moved away from the use of interim beds and introducing a more flexible interim home assessment recovery approach in our care homes. And this learning has supported our transformation programme for rehabilitation, which I'll come to in a minute. As already mentioned, we've implemented and reviewed the frailty pathway, and we've discussed some of that already around our improved length of stay and improved pathways. There are a few areas within this that we've removed from the strategic plan following a further discussion with different strategic approaches. There are 3 actions that have been removed out of here into the primary care plan, which are based around chronic pain management and pharmacological approaches for chronic pain and developing a GP resilience team. We've also removed the hospital at home service development following the IGB decision a few months ago. Work undertaken in phase 3. We've reviewed the post-diagnostic support for people with dementia, and this is reviewed on an annual basis with an annual report available should others wish to receive this. In 2024, 457 people received support across all localities in Perth and Kinross, while there were 50 people waiting on a waiting list in South Perthshire. And we're trying to tackle that with an additional worker to tackle the backlog. An additional 100 people per year are being diagnosed with dementia, and we refer back again to the service level agreement with Alzheimer's Scotland and the funding that's come annually from the Scottish Government. As already mentioned, Alzheimer's Scotland have developed a brain health and dementia resource centre in George Street in Perth, and we've taken an approach to develop dementia cafes across Perth and Kinross to support patients, carers and families. In addition, there are some small-scale unfunded improvement projects ongoing as well, which are improving processes and access for people with dementia. We've also provided a structured support to older people diagnosed with cancer, and that's a joint funded project between Macmillan and Scottish Government. We continue to build on our Falls review, and we're currently reviewing the community pathways across Tayside, and we're trying to integrate that into our local integrated approaches in Perth and Kinross. Most of this is focused on falls prevention education and in collaboration with our Live Active Leisure Wellbeing coordinators, who are now delivering postural stability training, which is a more evidence-based approach to falls reduction. And again, it's an access point for education advice for community services, community hospital ward staff and the public, and we can provide updates if required by teams locally. Further work that's sitting in this programme now and is now sitting as part of our IGB strategic plan. We have 3 work streams that are sitting in older people, optimising independence and quality of life for older people at home, enhancing dementia services and developing a person-centred approach to rehab and reablement. And these will form the basis of our work going forward. Funding totalling approximately 8 million was earmarked to support the delivery of the Older People's Plan, and due to the timing of the investment and ongoing recruitment challenges, some slippage was experienced in 2022-23, mainly due to recruitment. This was reported as part of the regular financial reporting to the IGB and was considered as part of the 2023-24 budget conversations. Perth and Kinross is currently undertaking financial planning for a 3-year plan from 2025 to 28. However, we probably should say there continue to be recurring financial pressures within the older people's services, which, as already mentioned, are driven by an increase in demand for health and social care services from an increasingly elderly population, complexity of clinical presentation, which is impacting capacity and flow through our hospital sites and community services. These recurring financial pressures are significant and may impact on our ability to deliver on strategic objectives going forward. In summary, the paper describes the work undertaken over the last 12 months to fulfil the strategic objectives set out in the Older People's Plan 2022 to 25. Significant progress has been made towards achieving our objectives, which were to intervene early to prevent ill health occurring and to support older people to remain active and independent for as long as possible, to shift the balance of care into the community and away from a hospital-based model, and to optimise capacity and flow in our inpatient settings, to enable people to return home as quickly as possible. As the delivery plan comes to the end of its life cycle, the programmes of work described in this paper have been adopted as business as usual, and we will continue monitoring and value the progress of these. The context which has governed our actions and operationing the plan remains challenging. Our population continues to age and to present with increasingly complex combinations of health and social care issues. These factors are compounded by the ongoing effects of COVID-19 infection and the challenging financial landscape. Our partnership staff and our staff in the third and independent sectors continue to work incredibly hard to provide high quality, person-centred health and social care services, ensuring that the improvements we have implemented are maintained and refined where appropriate. There is still work to do, as we've described in the transformation programmes highlighted in the paper. As the current delivery plan nears the end of its life cycle, these programmes will form the basis for a short-term plan to deliver on year one objectives outlined in the IJB strategic plan, and then as we pivot into defining our long-term strategy for older people in Perth and Kinross. Thank you.
Thanks very much, Amanda. Do we have any questions or comments? Progress update. Oh yes, sorry, Sheila, you had already notified that you wanted a comment and a question, please. Councillor McCall.
Thank you very much. I take it you can all hear me okay?
Yes.
Yeah.
Yeah, good. First of all, Amanda, thank you very much for that comprehensive report. It was a very impressive amount of work done in actually a relatively short space of time, given when we started in 2022 and all the challenges that were there. So I just want to commend you and everyone involved in the work that's been done and what's been achieved. My question is a more general one about the longer term strategy, though, because, you know, as part of an age-friendly city or age-friendly community, there's more than just health and social care as part of an older people's strategy. So I'm really just wondering, how do we engage with, for example, Perth and Kinross Council and areas like the built environment, housing, transport, all of those other things that would support a wider older people's strategy and perhaps more in keeping with the age-friendly communities.
Thanks, Councillor McCall. We probably should rely on Zoe really to give us an update, because I know that Zoe's very well connected into the groups across Perth and Kinross Council, and we're supporting some of that in the background. My understanding from Zoe's thinking and the feedback, and Chief Officer may want to come in and support here, is that we will use the age-friendly group and network and some of the work of the CPP, you know, the Community Planning Partnership, to enhance those relationships and connect those strategic conversations and really take forward an older people's plan, as you say, because it's much wider than just the older people's services. And you strike on a good point where we've been quite challenged. We've felt like we've worked in a little bit of a silo, if that makes sense, in terms of the partnership, because it is very much wider than just what we are delivering within health and social care services. So I think there's a need to obviously to embrace that and to work with people in a wider context. And I'm happy to take that back to Zoe and kind of firm up our feedback back to you, Councillor McCall, if that's helpful.
Yeah, you know, I mean, I sit on the Housing and Social Wellbeing Committee, for example, but I know that most of the service committees would have some sort of contribution to make towards a more longer term older people's strategy. And I think, you know, we need to all be working in tandem at the same time, because the danger is, you know, one area will go off and work on their own, but something else might not come along. So certainly something worth thinking about, and happily I'll catch up with you after, perhaps once Zoe's back.
Okay, thank you.
Thank you.
Thank you. And if I wonder if I could bring in Rachel Nathanson. Rachel, I think this might be your first time on board.
It is.
Yeah. Come in on that point, but just want to.
So yeah, just very briefly. So I'm the quite recently imposed team leader for policy and commissioning, and myself and Zoe and Andrea, who's the policy officer for older people, met with last week to discuss what this care strategy looks like, and you're absolutely right, Councillor McCall, in terms of there's actually only 2 domains under the age-friendly communities approach that would fall within health and social care. However, we are already, so the community engagement team, which sit within my wider team, have done really well in establishing kind of stronger communities meetings, and they're kind of in the process of transferring, diversifying into becoming older people's forums, but they already have really kind of good links, much more widely than health and social care, and transport are definitely involved in a lot of our discussion. We kind of need to get kind of more into kind of housing, but also CLD are kind of co-run those stronger communities meetings with us. The our challenge in expanding that will be getting the momentum to get these kind of set up, and there is absolutely an appetite across different localities to take that forward and make those developments meaningful. But with only 2 of, I think it's eight domains sitting within health and social care, we can get the momentum to get it going, but we also then need to look at how that is sustainable going forward, because it will limit the development of that as a kind of a whole systems approach if it continues to kind of be absolutely led by health and social care. So those are some of the discussions that we're having at the moment, and kind of reaching out, and absolutely we'll be able to kind of provide further updates. We've currently in the process of kind of benchmarking how other areas are kind of working, and there's some really interesting developments within Scotland, but also particularly wider. Ireland's taken a really kind of progressive approach to a lot of this stuff, and we're meeting again kind of mid-January to see where we're up to, and allow that to kind of inform some of that strategic development work. I hope that answers some of those questions.
Thank you very much. Black, you had a question.
Thanks, Amanda. Thank you very much. A great presentation. A lot of great work being undertaken. You may have not been able to help me in this one. On the community alarms, they now stabilising at 3,900, but we've got 12,367 devices in place now. Are they analogue or digital? Because partly what I asked that when you try to transfer over your telephone, like Sky or things like that, you have to go through a separate department if your community alarm is analog. And it's not the easiest process.
So you might recall, Martin, that we had an update at the Audit and Performance Committee, just I think it was a couple of, I'm looking for Sheila, but you're on the screen, a couple of meetings ago, Sheila, we had an update from our lead on the digital, analog to digital, and I think they advised that we were about 93% through the programme, which was well ahead of the game, and I think that had achieved us a gold standard recognition on that. So very good progress has been made in transferring, so the majority should be digital, but I appreciate we're not fully implemented the whole programme yet.
Sure, that should have been listening.
You've just got so much going on.
Do you want to come in at this point?
Well, no, I was just agreeing that they are very efficient with changing things over to digital, because certainly the community in which I live, they have swept through and done very nice. I actually wanted to ask a question about something else, if that's okay. One of the things I've noticed being, well, funnily enough, living where I do, where they're all kind of older people, there are varying degrees of decreased mobility going on, and there are quite a lot of individuals who, having been previously not just ambulant but actually quite active, are now finding themselves in a situation where their ability to maintain their balance has been quite severely compromised for various ongoing reasons. And that we have in Perth the mobility that you can use, you know, with the Motability, with the scooters and things, which is fantastic and very helpful for people who want to be able to go around the shops and who otherwise wouldn't have the ability to walk it. However, this is only in the centre of Perth. Where I'm looking at are people who live out with that or in other areas within Perth and Kinross who don't have ready access to this. They don't have anywhere to practice, and they're actually quite anxious and quite afraid of using a scooter because they're fearful of not being able to control it. And in the spirit of hoping that we can maintain more independence in older age, and we can encourage people to actually be able to go out and, for example, go to the shops themselves, I'm just wondering if there's any thought about how we could provide training opportunities, you know, to give them a bit of a go and see if we can encourage them to do this a bit more. And the reason I'm asking about this is I have actually been encouraging people in my own lunch and, you know, other social clubs for older adults with the fact that if they went along to Motability, they do give them a wee bit training there. And if you get a taxi there, there's actually a seat directly outside the office. You can literally transfer from a taxi straight onto a chair, and then they'll bring up a scooter. So again, it's immediate transfer. So they don't have to be fearful about walking very far. It's just ways in which we can maybe look to encourage this. So I'm just wanting to throw it out there and see if there's any.
No, I think that's a really good point, and I know that they're doing that in other areas with other things. For example, they to try to expand kind of electric bike usage. For example, yes. People can now come and borrow, like there's the Aberfeldy Transport Hub and things like that have that. So I've made a note of that because I think that could be a really kind of good development, and we can kind of catch up about that. It's a great time for these points to come up when we're looking at what a kind of age and well strategy looks like. So thanks.
Okay, I'm looking around the room and online, and I'm not seeing any more questions or comments. So thank you very much for stepping into the breach, Amanda, and for introducing the report. Can I invite the board to note the significant progress against all programmes of work outlined in and funded under the Older People's Strategic Delivery Plan 22 to 25, and to endorse the intention to refresh the Older People's Strategic Delivery Plan to align with our new strategic plan and take a longer term approach to how we plan for older people's services by the introduction of a 10-year age of wealth strategy.
Great.
Thank you very much. Okay, we'll move on to item 7.6 on the agenda, which is the Connecting with Communities for Change, which is our participation and engagement strategy for 2025 to 28. And Rachel, I think you're going to introduce the report.
Thank you to the Chair for the opportunity to speak to the strategy. A little bit of background is that kind of all kind of policy around health and social care has progressively moving towards kind of participation and participatory means since kind of the Christie Commission report in 2011, and that's been it's become a statutory responsibility for IJBs and other public sector organisations through the Scottish Government's planning guidance, which was refreshed and relaunched February 2023. And so this draft strategy is being presented for your approval, and to give members the opportunity to ask questions and assure themselves that the proposed actions outlined will allow the IJB to fulfil its obligations with regard to kind of public consultation. So the Connecting with Communities for Change participation strategy is our kind of blueprint in order to ensure that we're keeping communities connected to our plans and that our ongoing service development is co-designed and co-produced wherever that's possible. It's taking a nothing about us without us approach and recognising that community voices are foregrounded through a collaborative approach to service design and all of our working relationships. So we've had early discussions with communities which have informed the development of this strategy, and some of those indicated that they felt that the same voices were always heard and that the more vocal groups tended to be prioritised, and that too little was being done to really reach out to people who felt disengaged from and disenfranchised by existing partnership engagement processes. And so we recognise that people really need to be engaged from the start, from the earliest possible opportunity to be so, and to have real involvement and influence over planning decisions. The challenge for our teams is in translating these conceptual frameworks, a lot of which are contained within the strategy, into real world kind of actions and activities that put our communities right at the heart of all that we do. But I think the previous discussions we've heard this afternoon really kind of underline the requirement for that running through all aspects of the IGB's kind of work. So there are significant sections within the strategic document which detail the approaches to co-design and co-production, and we've also continued to use case studies because we're aware that these things can be quite intangible for people to try to grasp what we actually mean by this. What does it look like kind of out there when we're working? And my hope is that these really foreground good practice and demonstrate the ways in which different groups within the partnership can come together, are already come together, and how we can kind of expand and broaden and build on that. Early research highlighted that 64% of the people in Perth and Kinross engaged around the strategy and also the joint strategic needs assessment had no idea what the Perth and Kinross Health and Social Care Partnership was, and that is a significant obstacle when it comes to our engagement with things, and actually the reality is that we brush up against and intersect with these people's lives in a whole variety of hidden ways, and so that combined really demonstrates the need for a kind of a new an improved community outreach and engagement programme, which I think the strategy kind of details, so that people can better understand what we do and the supports that we make available to them, and how they can be more involved in decision-making processes. So a big part of this work will be around creating the channels to make sure that community feedback and input gets to the right teams and individuals within the partnership itself, which then enabling better conversations between the partnership and these different communities, and between the different staff groups across the organisations involved in service design, implementation and the day-to-day provision of services. Staff and community members have highlighted some concerns around how their skills and experience could be of benefit, and there's a kind of quite a wide degree of uncertainty around how best to make a meaningful contribution. And so a lot of this strategic work, particularly over this first year and next year's planned programme, and this initial strategy is really about looking at how we can build some of that confidence and build those skills across participant groups, be those kind of staff groups, be those kind of public, so that over time the meaning of our conversations that we're having and the meaning of our involvement can continue to kind of deepen, and we can kind of really all mutually benefit from the richness of that. There's quite a comprehensive action plan has been developed, and from my perspective as someone whose whole research area is how we elevate lived experience and really elevate those voices and make them meaningful and deliver them to people who might never engage with those voices in the course of their day-to-day work. I'm really excited about being able to have this it's a kind of almost more of a formalising of a lot of the work that my team does, and allowing that strategic focus to come onto it then allows more accountability for us to kind of report back. So I'm kind of looking forward to being able to report back updates as we go along. So just in summary, the strategy speaks to our obligations, but it also, for me, we're not starting at zero on this. We're trying to bring a little bit more cohesion and make everything that we're doing more comprehensive. And it's not only about obligation, it's actually about what we know is best for communities and what communities have been telling us for quite a period of time. And so we're asking the board to approve the strategy so that we can move forward with the implementation. And I love to take the chair and invite questions. I will also say that I'm a bit of a last minute stand-in with this because Zoe's given her apologies, so I may not be able to answer everything. But if I can't, then I will absolutely kind of go and find out and feedback. Thank you.
Thank you very much. Have we got any questions for Rachel?
Thanks for that. It was really interesting. I am just wondering round about the UNCRC, so the United Nations Rights of the Child, and that was incorporated into Scottish law earlier this year. We certainly had lots of education about that from the Child Health Commissioner, and there is certain components of that act that tell us that children need to be involved in planning, and if we're going to be taking away a playground or whatever, what impact does that have on the children in the local community? I just, from the list here, I guess there are a couple of user groups that involve children, but I guess I would like an assurance that the voice of the child is going to be incorporated into that, because I see that a lot of them are kind of older people's groups rather than younger people.
It is, and I think it's challenging because our remit is with adults. However, actually within the team, and I mean that turns in community engagement and also policy, if you're going to have kind of there's engagement happening and participation happening across the board, but we're kind of trying to bring that cohesion. There's that real sense that we absolutely, for this to be kind of strategic and have that long-term vision, we need to be looking at what's coming through. So the team are already linked into children's services and working very closely with them, particularly around mental health, so that we're trying to kind of build that. And in terms of actual engagement opportunities, I'm not entirely sure what that looks like with kind of under 16s, but it is on the radar that's very much something that needs to be kind of incorporated into this, because we are looking at quite a lot of this. While there are some quick changes to practice that we can probably make through a lot of these activities, a lot of this is a much longer term, and really trying to imagine what we hope that services look like in the future, and that has to incorporate those voices that are actually going to be needing and requiring those services in the future, or maybe. So it's a really valid point. Thank you.
And Chief Officer, you want to come in?
Sorry, Jackie. I'm very sorry to go, as I mentioned to you earlier. I can't change the taxi time.
Thank you. Thank you for attending.
Thank you. Nice to meet you.
Bye.
Just an answer to your question. Just like, this is the Health and Social Care Partnerships strategy, and children's services are not delegated to us either by NHS or by the local authority. So the responsibility for that engagement is sit with those services that are primarily focused on working with children and their families. However, we do have responsibility as a board to ensure that we're carrying out assessments that we consider. So the contained within our report is an impact assessment.
Scott.
Thank you very much for your and it's lovely to see this is still ongoing. 30 odd years ago, I was a community learning development worker getting a degree, and the very same questions were being 30 odd years ago. How do we engage with community? I think it's wonderful that you've got to do it in 5 communities. When we started off, there were 90 definitions of community. And so you've got 5 definitions of community. But it's still, how do you engage with the hard to reach people? How do you get their voices heard? How do you hear us who can very little about the reasons and purpose of engagement? How do you engage with people who are substance use? How do you engage with people, 30% of the population who can't read and write? And how do you engage with that? And how do you get, because the same voice has been heard, that was 30 years ago. Alan Barr wrote a book about that when he started the Community Development Foundation. How do you get your voice heard? And how is that respect it to be heard. We go and ask people questions. We should be listening to the questions people are asking us. And that should be the most important factor, because it's the impact that's on their life. So how do we change this perception? Or if I live for another 30 years, I'll be reading the same things.
Absolutely, and it's a big challenge, and I'm not sure that we have all of the answers, and that makes this quite an interesting strategy to try to, because with its ethos, we have to be vulnerable enough to be uncertain about it and to be uncertain what progress looks like in these things, because otherwise we're still coming in and saying that we're the experts and we know it all. And I think what's absolutely clear is that we don't. I think we've been really kind of working towards kind of capacity building and relationship building with a whole variety of groups, and consistently, our plan is to consistently reflect whose voices aren't we hearing, why aren't we hearing, and how might we be able to. So I think there's a big focus on outreach work and kind of to where places are, and also trying to kind of show up in ways that are meaningful, rather than, oh, the people from the partnership are coming to talk to us about something. Actually kind of make it a little bit more meaningful. And I think there's there are ways that we can kind of get better at that. So actually one of my team is kind of involved in quite a few things kind of up at Murray Royal, and really kind of how we get the voices of kind of there. We're looking at people that we kind of who are maybe in kind of sheltered housing or things who have services in, so are not that most vulnerable and not disconnected, but also voices that aren't very often heard. I think tomorrow we've the brief list of projects that kind of comes at the end of the action plan in this is quite kind of deliberately put in so that we can try to explain the journey of what works and what doesn't work. And I'm kind of anticipating that some of those won't work out, but we'll learn as much from those as we learn from the other things. One of the things on there is Perthshire Welfare Society, and I don't know how much about them, but they kind of reach it's people who are very much out of the system and not really accessing services. And I think that's it's through building these relationships and these links with real kind of grassroots organisations and community leaders and things that they can help us kind of steer into some of these things. We've also got an academic at Napier who has already linked in with one of our elected members around some research, for example, with the ethnic Chinese population within Perth and Kinross, and he's doing his own research, but has also wants to collaborate with us so that we can find out something about their health and social care needs, whether that's around kind of ageing, unpaid caring roles and things like that. So it's really trying to maximise the existing networks that we've got, but also not be complacent in what those look like, and consistently and ask for help and advice and from people who do know this, how we engage kind of a little bit better and really try to create that learning culture and be okay a little bit with the uncertainty of are we doing enough, could we do this better, and consistently kind of ask ourselves and others those questions. So sorry, I don't know if that's a little bit of a non-answer, but
no, there's a lot good in that, but it's a bit actually, see if we're working with other agencies who have different agendas, it has to be a community development ethos across housing, across police, across social work, across education. And you've got community learning development workers, you've got capacity builders who can engage with communities to bring the best out of that. I still see old Arnstein's ladder of participation. He must have been a fortune on that way.
Thank you.
It's all in houses.
Not seeing any other requests for questions or comments in the room, so if we can just move on to the recommendations. And we approve the Connecting with Community for Change, which is our participation and engagement strategy 25 to 28, and the associated action plan request an update in 12 months' time and issue the direction as set out in the report.
Agreed.
Thank you very much. Rachel, thank you very much for attending for that item and for your attending for your first IGB as well.
Thank you all for
Members, we have next the strategic planning group update and the lead partner services update for Angus IGB on the agenda. I think it is probably more important, given the time, that we move on to 8.1, which is the 24-25 financial position for the Chief Finance Officer, if that's acceptable. If there's time, we'll come back to the strategic planning group update, but it would be my intention, especially as the Chief Officer of Angus, who was going to provide the lead partner services update, wasn't able to be here today. We can move that one over until the next meeting. Chief Finance Officer.
Thank you, Chair. I'll keep this deliberately brief to allow for questions that happen at the end. But this report provides the forecast financial position. It's based on expenditure and performance up to the end of September 2024. So that's reflecting the month 6 position. At our last IGB meeting on the 2nd of October, we reviewed a financial update that projected a £1.6 million overspend. And we considered a financial recovery plan that aimed to reduce this by 1.3 million, bringing us close to a break-even position as an IGB. Unfortunately, this latest information indicates a deterioration in this projected outturn. As outlined in section 4 of the report, good progress has been made on the financial recovery plan. There have been considerable work and actions undertaken which are leading to the projection of full delivery of the actions. And I'd like to thank the finance team and the service management team that have been involved, because there has been considerable work ongoing since we last met to deliver on that. However, there has also been a deterioration of 936,000 against the core position, and this is described in section 2.8 of the report. This change is due to a cut in Scottish Government funding and due to an increasing need for additional care packages within adult services. Both the uncertainty of Scottish Government funding and the increasing demand and complexity of care packages were identified as key risks to our financial position, and they remain significant risks within this report. Currently, we are projecting that after applying all general reserves and realising all financial recovery actions, the year-end position is forecast to be £1.2 million overspent. As noted in the report, the finance team and service management team are making every effort to mitigate outstanding risks and to reduce the projected cost pressures wherever possible. I wanted to note that the report also provides an update on the delivery of savings, with all £3.1 million local savings being achieved in full. However, there is a projected shortfall in delivering the prescribing-related savings, as reflected in the overall position I described. Finally, the report includes a brief update on the 25-26 budget. I've deliberately kept brief because at the time of writing this report, the draft budget had not yet been announced. But also, all IGB members will meet next week on the 20th of December for a full budget development session. And during this session, we will consider the pressures facing the IGB next year. We will discuss the implications of the Scottish Government's draft budget, and we will seek to develop the 3-year budget and financial plan for the IGB. Mark, Grant, the finance managers, join me today. We're both happy to take any questions you have on this report.
Thank you very much. Do we have any questions?
Is the new predicted outcome, does that include taking away all the reserves as well? So
yes, that's the position after all reserves. We would say that the majority of that movement, that predicted, so a portion of it is about the Scottish Government funding being cut very late in the financial year, and entirely unanticipated by ourselves.
Yeah.
The remainder is around a small number of clients requiring unanticipated level of care package increases or new packages because their situation broken down, and they are clients with significant complex needs, and these have all been looked into quite thoroughly. and everything's been done to support the clients.
When you say a small number, is it less than 10 or 20?
Yes, yes.
Less than 10, okay, thank you.
I suppose you just to put that into context, a package of care what would the variation be?
Could be anything from a £20,000 annual package or less, right up to 300, 400.
Could we go bust?
No. So what happens at so just for some reassurance, and I was saying in the introduction there's a considerable amount of work going on. The finance team, along with the service management team, are looking at absolutely everything. So all expenditure that we're incurring, we're looking through it, and we're supporting the teams to make best use of the funding that we've got. We're being very strict on our control around vacancy, although ensuring that services are being safely delivered. We're being very strict around day controls. Everything's been done to make sure that expenditure is minimised to the end of the financial year, anything that can be avoided. And what would happen at the end of the financial year is our risk sharing agreement would kick in. So we've applied all our general reserves, we've applied a financial recovery plan that, had we not had that cut from Scottish Government funding or the small amount of packages come in, I would have been reporting to you today a successful story on saying we came to you last month or a couple of months ago and we projected that we would deliver a financial recovery plan to bring us very close to break even, and we would be there. So the efforts that we've put in around our financial recovery actions are projected to deliver. We've also found other things that we can apply, and we'll keep applying them, and our next report will hopefully show a benefit. But what we can't minimise, or we can only minimise so far, is the risks that are remaining. So in section 7 of the report, you see the risks that remain, and unfortunately there's still an outstanding Scottish Government allocation that we do not yet know. We're trying to do everything we can to mitigate that risk and ensure that we're ahead of it, and making sure that we're only operating within the envelope that we've already got and no longer assuming we'll get any more. So we're doing that. But care packages and prescribing are the part that, for us to deliver safely, you can't necessarily control.
Okay.
And I was at a meeting of the chairs and vice chairs of IJB's chairs and vice chairs network of chairs and vice chairs of IJB. That's really difficult. Yesterday, certainly all IJBs, apart from finding themselves in the same position, all IJBs have the same challenges around prescribing, in particular, and it's an uncontrolled cost for health and social care partnerships across the country. We'll come to Mr. Campbell.
Sorry, yes, just on what you've explained there, Donna, and thinking about the first part of our meeting where we were talking about delayed discharges and how positive that has been, and the question about readmission, which relies heavily on community services to ensure that these. So when you're having to be really scrutinise the finances and what can be delivered, that's likely to put us in a position that we could be back to square one again, or does that make it? So have we taken that into consideration?
Yeah, we very much have. So the financial recovery plan that was presented on the 2nd of October did everything that it could to avoid that exact situation. You may be aware of other partnerships that have presented financial recovery plans that have talked about waiting lists and limiting and restricting, and the impact of that may be that somewhere else in the system that it becomes a backlog. What we have done with our financial recovery plan is really tried to emphasise the efficiency element. So where we felt that there's perhaps an over-prescription of care, or there's a lag in a process, it's tightening up that. It's making ourselves as efficient as possible with the capacity that we already have, and tightening up that as much as possible. We've enhanced the resource allocation group meetings, so they're now a wider group of people that are meeting. It's more of I think it was already a multidisciplinary approach, but there's a wider team there looking at packages and looking at asks for care now, so that there's actually maybe perhaps a better outcome, but it's probably a better way of working, and we're emphasising on that as much as we can. but I appreciate it might be to a point, and that's something that we'll need to discuss next week when we're talking about the budget, about where do we go, because our finances are finite.
Thank you.
But we've tried to prevent that as much as possible.
Mr. Black.
Between 3.9 and 3.11 on the page, and in one case we're telling that the 234,000 has been increased because of the packages, and the 13% increase that's on delivery, and the fact that the Scottish Government have hammered us for another $500,000. But when we go down, then we've got an underspend on care and support is 768.
So
explain that to you.
Yeah, certainly. So you'll all finance reports, you'll see there's unders and overs. It's just the way it goes. As you know, setting a budget and setting a financial plan is a plan, but you never know, and particularly in a people service, you never know what's going to happen. So against the budgeted level, what we were anticipating at the start of the year based on trends and demographic, we had built in a certain amount for the services that we're talking about in 3.9 and 3.10. But what's coming through is in excess of that, and the rate that it's increasing is in excess of anything that we had even a buffer for. What's happened in 3.11 and 3.12 is something again that's not been anticipated, but we've budgeted for something and it's not yet been, there's expenditure not yet been incurred. So if we were going strictly back to the plan is that the packages that were involved under 3.12 there that are generating an underspend, the packages were planned to have been in place by now. But whatever's happened or caused their delay, it's that delay that's built up that underspend. It's not that the package is still not required on an ongoing basis, it's just there's a delay. So the financial report's really going back to what we've planned and budgeted for, and we're reporting the variances against that, as opposed to there'll always be unders and overs across.
The 13% that you're identifying roughly, would that be applied to that 768?
It tends to, on bottom line, they offset each other. Do you know, it offsets each other this financial year. But the problem is when you go into next year, if all the packages that are planned are now in place, and we keep seeing that increase that we've seen, and that's maintained or it keeps increasing, we don't have enough money. So this year they're offsetting each other perhaps, but next year they won't, because you're going to have everything in place.
I have to say I have great faith in what you are doing. As a member of this IGP, I always feel confident in what you're trying to achieve.
Yeah, I suppose just on that note about thinking ahead to 25, 26 and beyond, John and I spent quite a bit of time both within Perth and Kinross Council, with the executive team here and elected members, and with NHST side, and we're ensuring that these pressures, which are not just within year but actually will go on because this is about increased need across our population, are cited within reports that are coming forward to both council and NHS boards. So we've provided some of the information that's set out here to ensure that there's an understanding across those bodies of the pressures within the Perth and Kinross Health and Social Care Partnership.
But the pressure in the boil is getting harder and harder and harder. It's going to have to burst sometime. And it's going to have to burst something, and that would have to be across Scotland, not just for here.
It's something better than a boil. Sleeves is always been that.
I would think about the chocolate cakes I was eating.
Councillor McCall.
Thank you. I suppose just following on from what Martin says, that the pressures are keep increasing, and I know, Jackie, that you and Donna have been talking to, our partners in the council and in the health board. But do we need to do something additional to project what those pressures might be like over the next financial year, rather than just saying this is what we need for the status quo? Is there something else we need to do to try and model going forward?
Well, we have done that. We have, and I'll be able to talk to you about this next week when we meet. We've got different scenarios. We've got that high, medium, and low scenario, and the medium is based on us maintaining the level of demand that we have just now, but building something in for demographic increase. The high is that we continue to see this sheer acceleration that we've seen this financial year. Now we're hopeful we'll start to see that acceleration tail off, but we don't know if it will or if it won't. But we do already have kind of 3 scenarios: the low, the medium, and the high, for going into next year and then the following 2 years after that.
So I suppose the question is, how do we persuade our partners that they should budget for the high and hope for the low or medium? Because I'm not 100% convinced that the demand's going to tail off, or the increasing, you know, that's other than just based on what we've seen so far this year.
Yeah, so we're definitely building in the medium scenario, and that's the one that we've discussed most with partners. We're definitely building in the medium scenario a continued increase, but we've linked that to our demographic. Some of what we've seen this year, we're still not quite sure why it's accelerated at the rate that it has, to be able to see if it's or not. But yeah, we've certainly built in some increase, but not to the same level we've experienced.
You could be the victim of your own success by providing such a fantastic service that more people are coming looking for support.
However, all our services would be based on a level of assessment in terms of that need. So, you know, requests don't necessarily equate to delivery. So and I know that we provided information previously around the fact that when we are doing a deeper dive into our packages of support and care, that people are very much at that higher level of need and assessed need. And I know that some the reports that have come forward today and previous IGBs are also meetings are also setting out very clearly the extent to which we're supporting prevention and earlier intervention. So it's not as a result of the lack of attention to that. So this does need to link into our population projections and our strategic needs across Perth and Kinross. You're right.
Can I ask another question, Chair, if I may?
Yes.
Thank you. So the increase in national insurance for employers will have an impact on a lot of our providers. When we put together the low, medium and high scenarios, did we fully factor in the full supply chain impact?
For national insurance, no. No. But I can go through that with you next week. No,
I think we're going to have to, maybe, only because I've become more acutely aware of it from third sector organisations who have mentioned it, and indeed some private sector organisations. So it's quite a big issue. I think that we need to somehow factor that in. That doesn't necessarily affect demand, but it might affect ability to deliver.
Okay.
Okay, thank you.
Under the inpatient mental health section there, Perth and Kinross previously hosted the inpatient services has now been delegated to the 3 IGBs across Tayside. But it says that currently there is no budget delegated to IGBs for 24-25. Now that is a huge, probably the biggest demand on the mental health budget. So how are you just working on estimated figures now? You know, if there's.
So that's been the situation since 2020. There's been no delegated budget to Perth and Kinross. So the budget sits with NHS Tayside. It's not delegated to IGBs at this stage because of the situation that we're in. So that has been the situation for the last 4 years.
It's not good. I mean, it needs to be, you know, you need to know, you know, what you're working with, like, you know.
operational responsibility sits with NHS Tayside, so we do get monthly reports, we do get insight into the costs associated with that, but we're not operationally managing it, and that's probably what you're.
So they were delegated to the IGBs is actually Tayside.
So the three IGBs jointly set the strategic direction for inpatient learning disabilities and mental health, inpatient physical health and learning disabilities, with Jackie as the lead partner for that. But all of the management in terms of the staffing and the properties and the budgets and the sort of direct line management is done by NHS Tayside, and it goes up to Sandra, who was on the call earlier, Sandra McLeod. That's right, isn't it?
Well done.
Okay, are there any more questions or comments on the financial position? Not seeing any. So can we note the overall projected outturn for 24-25 based on financial performance for the 30th of September? Note that the Chief Officer and Senior Management Team continue to work on and to review actions to mitigate cost pressures within the current year, and note that the update on the financial recovery plan and to note the update on the financial recovery plan and the financial risks as detailed in the report.
Agreed.
Thank you very much. Next item on the agenda is the Audit and Performance Committee update. Can I pass over to Councillor McCall as Chair of the Audit and Performance Committee?
So I just have to unmute myself. Thank you, Chair. So since we last met, the IGB Audit and Performance Committee has met twice on the 20th of October and the 25th of November. The meeting on the 28th of October was a special one-item agenda meeting to review and approve the audited annual accounts with the appointed auditors from Audit Scotland in attendance. There was no significant findings that would require any adjustment to the accounts and no incidents of fraud detected. So the accounts were duly approved and signed off. As a general comment from Audit Scotland, and Donna mentioned it earlier on there, that the current financial model, in their opinion, for health and social care partnerships generally, they're questioning its sustainability. But at the moment, we have what we have. They also noted, the auditors, that the recovery plan is very much dependent upon funding from partners who themselves are under increasing demand and associated financial pressures. Nevertheless, the accounts were approved and with no qualifications, which is a good thing. The meeting of the 25th of November was a regular meeting, including standard updates on transformation, financial recovery, KPIs, clinical care governance, etc. Demand for services, as you've just heard, remain high and are increasing, posing ongoing financial and operational challenges. But based on the information brought forward and the evidence from officers, I'm satisfied that the finances and performance of the Health and Social Care Partnership are well managed and that there are appropriate governance arrangements in place. At the same meeting, our internal auditor provided an update on the progress of the internal audit plan, and everything is progressing as scheduled. One area to note is that there is a new global internal audit standards that will be effective from the 9th of January 2025. And it affects all public sector organisations, or all internal auditor organisations actually. And within that, there are explicit responsibilities for audit and performance committees. At the moment, CIPFA Scotland is preparing guidance that will hopefully be available early in 2025, with the ambition by internal audit to complete an internal review of the IGB Audit and Performance Committee's work against the new standards by the end of this financial year. So we'll have to wait and see, but the unofficial view is that there probably isn't too much that might need to be changed or tightened up, but we'll have to wait and see. But certainly by the time we come to our next meeting in March, I would hope that we'd have a better update for you on that. Finally, the only other point I would really like to make is we have a few meetings throughout the year that are single item agendas, such as the annual accounts. So some work has been done to see if we can structure our meetings to remove the need for the single agenda item special meetings and incorporate them into our regular scheduled meetings. So I would hope that, I know officers are working on this at the moment, and we would hope to bring forward a paper to this board on a proposal to reduce the number of meetings and incorporate the single item agenda meetings into the regular meetings. So that is all I have to update you on today.
Thank you very much. Do we have any questions for Councillor Cole?
Just thank Councillor Cole for chairmanship and input from the finance team as well.
Okay. Thank you very much. We will move on then to the next item on the agenda, which is an annual summary on directions, as a very brief paper, so I'm prepared to over at 5 o'clock. There's take it on, have to go over pages of a report. Chief Finance Officer.
I'll be very brief, and thank you to Phil Gerard, who's with us today for helping prepare this report. It provides the IGB with a summary of the directions which have been issued by the IGB, Perth and Kinross Council, and to NHS. The report explains the purpose of a direction and what it should contain. There is a statutory guidance provided by Scottish Government on directions, and it states that a log should be regularly monitored and reviewed by the IGB. And this was an action that we included within our partnership improvement plan. And this report is the first annual report with Appendix 1 detailing all current IGB directions. After today's summary will now be brought to the IGB annually. And that's really all we needed to take any questions.
Okay, I'm going to trust that there are no questions.
Very helpful.
Okay, thank you very much. Can we note the report and request a further summary in 12 months' time? Agreed. Thank you very much. Few items were put on the agenda for information. You can send them out as papers in the document pack and linked. So the first one was the Tayside Winter Resilience Plan 24-25. It was actually a much larger document pack, so it starts on page 104 onwards. As Councillor Cole was referring to the audited annual accounts, there's a link there. I think if there are any questions on those items, they can be fired in off-site. Item 10.3 on the agenda is the work plan for both the full board and for our development sessions in the alternating months. Any questions on the work plan? Future meetings? No. And then we have future meeting dates for approval. Can we agree those future meeting dates for 24-25 and also the IGB development sessions?
Agreed.
Thank you very much. That concludes the business of the board today. Thank you all very much for your attendance and for your engagement. Thanks to all the officers for attending to the reports to answer questions. A final welcome to all of the new members that we've met today. And as we said earlier, thank you to Sir Ian. Given that it's coming up to Christmas, I would normally wish everyone a Merry Christmas and a New Year, Happy New Year when it comes, but we have got a development session on Friday of next week. So I'll maybe save the mince pies and mulled wine until then. Thank you all.
Thank you.
We got the mince pies.